Even though we don't officially have a quorum, let's go ahead and get started. I feel like we'll have some more joining us here soon. We're not taking any votes on anything, so we can listen and they can catch up online afterwards. I want to welcome each and everybody here to the fourth and final meeting of this House Study Committee. We tried to make each meeting a little bit longer to do a little more, and we'll move into the deliberations of what I know will be another great document to challenge us in this year particularly, but in the years ahead as well, to address this concern. Y'all, I'm so glad for the rain. I know that's a little bit why everybody's late, but isn't it glorious? I just kept standing out looking at it a lot during the night, actually, like it's still there, it's still there, it's great, it's remembered. Now if it can just keep doing it. Let's start this morning with a little bit of prayer. Dear Heavenly Father, we come to you today just to say thank you. Thank you for the dryness that you've given us and for the blessing of the rain today. Be with everyone as they travel here. Give them mercy and a hedge of protection on their way to the Capitol and on their way home. And we just ask that you keep helping it to rain. Lord, help us in this concentrated effort that we are making. Help each and every one of us to be mindful of all of those who are crying out for help right now. Help us to be the hands and feet that they need. Give us words to speak and ears to listen and eyes to see as we put together some steps that we hope will help. In your name we pray, amen. Okay, so we'll jump right in, and I believe both are working today, right now, as we go. So let's start. Our first presentation is Sulima Salgado, hopefully I didn't butcher that, the Telehealth Director for the Department of Public Health. And Sulima, if you would just, or David, if you are whoever, introduce yourselves and tell us a little bit about you.
Yeah, I'll be real quick. I'm David Bay, the Director of Government Relations for the Department of Public Health. We're here on behalf of Commissioner Brenda Fitzgerald, who sends her welcome to you. And I'll let Sulima kind of roll from here.
Okay, thank you. Good morning, I'm Sulima Salgado, and I'm the Director of Telehealth and Telemedicine for the Department of Public Health. And today I'm here to talk to you a little bit about a new initiative that we're working on in Lamar County. It's a school-based health initiative where mental health services will be provided and are being provided in a school setting. So with that, I'll go ahead and get started. I wanted to give you just a quick overview of telehealth and telemedicine for the Department of Public Health in case you weren't familiar with it, so you can really understand kind of how we came about into working in this program. I see a couple colleagues here that are helping us with the initiative. I see Erica from Voices. So it's good to know that there's a couple of people here representing the initiative as well. But the Department of Public Health has been doing telehealth and telemedicine going on 4 to 5 years officially from a state leadership perspective. A lot of our county health departments have been implementing telehealth and telemedicine probably for about 20 years, small scale in a lot of rural county health departments, just depending on the needs and the access to specialty services in those counties. But when the Commissioner Fitzgerald came on board, she really thought that telehealth would increase access across the entire state, and she wanted us to implement telehealth throughout the state of Georgia in our local county health departments as a way to increase access, as I mentioned before. We currently have telehealth capabilities in all 159 counties. We've got 157 here, but I'm proud to report that the last 2 counties are getting the equipment as we speak. So all 159 of our county health departments have telehealth equipment. And the way we like to look and distinguish telehealth and telemedicine is a little different. Telehealth is really more focused on the video conferencing piece of things. So you can do distant learning, translation services, one-on-one consultations, pretty much just the video component of it. So speaking with someone and interfacing back and forth via video. So kind of like your Skype and your FaceTime that you use on your phone with technology, but taking it a step further on an integrated, secure, HIPAA-compliant network. So without really having to use additional scopes and peripherals and tools a doctor may need to use, that's really what we like to consider telehealth. We also have 22 telemedicine carts successfully deployed across the state, and that really takes telehealth a step further. And what that is where we have additional scopes, an actual cart, or we have a nurse presenting a patient back to a doctor using additional peripherals such as a stethoscope, an otoscope, a general exam camera. Sometimes we have an ultrasound connected to it, or a colposcope. So really putting those additional hands-on services. And then, as you can see, pretty much our state of Georgia and the telehealth map, if you can see it over there to the side, the state of Georgia is completely covered. Like I mentioned, all of our county health departments have it. I like to use the map as kind of just a reference so that you can see we picked our health departments as the location for telehealth, not only because we're public health, but because we're very centrally located in each of these counties. If we wanted to make ourselves accessible, we knew we already had an audience who comes to the health department for services, but when looking at integrating technology and making it available in every county, we knew that our health departments were pretty central, so there's a good likelihood that everybody could get to a health department, whether it be with personal transportation or public transportation. Most of our county health departments are at a very convenient and accessible location. And this map kind of shows you, when you look at those dots, that is the physical location of our health departments where the equipment is located. So why use telehealth? Just a big picture again. Utilizing public health nurses for telehealth allows patients to see specialty physicians at locations where they may not be able to go for services. So if you're coming into a health department for immunizations or for family planning, if we could have this technology as we do and connect you while you're already there and make it kind of a one-stop shop for you, we think that that's success and very important. We know that no-show rates are high. We know that people can't come for follow-up appointments, whether it be because of transportation, daycare, etc. So we knew that if people were already coming to the health department, we wanted to be that asset and continue to provide additional services if they needed it. It also cuts down on the patient's missed appointments, so follow-up and adherence, we're able to monitor that and see how people actually follow up. And we also looked at it from a cost savings perspective, not only for public health, but for our families. We knew that they were already very limited in their travel time. We knew that they were already strapped to get for time off work to come in, even if it's for a flu shot. So if they were there, let's go ahead and take full advantage of them being in our health departments. Another success and another reason why we use public health as a location for telehealth and telemedicine from a provider perspective is it allows us to also connect people to providers in their local communities. Our goal for telehealth and telemedicine is not to connect people to services outside their counties or outside of the state of Georgia. We like to keep all of our services local. We don't want to extract people outside of their community. So if there are local providers in that community who see an increased number of patients, and maybe their patients are just having a hard time getting to that location, we're happy to connect them via telehealth if they're already coming to our health department. Once we realize that maybe there's not a specialist, let's say, for example, in Lamar County who can provide this service, then we look at neighboring counties so that their commute's still not that far if they have to ever go in for an in-person, and see what's available. And then if we don't have anybody in that surrounding community, then we look across the state. But we never go outside of the state of Georgia. And in the rare case where we have gone outside the state of Georgia, it's probably Alabama, South Carolina, but those providers have a Georgia license, so they're able to practice in the state, again, which is very important. All of our public health providers and presenters are trained in telemedicine using our educational platform. So we in the state have a telehealth training specifically for our public health nurses, just to make sure we know that the environment is very different from a private practice and how you see public health patients. And we also work with the Georgia Partnership for Telehealth if we need to for expanded training through their network for providers, if they have providers who are going to be on their network and on ours. We also think it's very important to know that the acceptable presenters are registered nurses, LPNs, or CNAs, and a lot of public health nurses meet those qualifications. So we're able to actually bill for those services. Depending on the type of service, depends how much we can bill, but we're guaranteed at least a presenter fee, which is what the commissioner thinks is just, it's very nice for us. It's not a lot. It's $20.52 per person we see, which again is very little, but for public health, any revenue is great revenue. We'll take it. And again, if we're already seeing the patients for something and we're really just connecting them, it's just an extra bonus for us to use that money, put it into an account, and help them with buying additional scopes and peripherals that they need based on the type of clinics that they have. So just to give you an idea what telemedicine would look like, you can see an originating site, and then you have a cart or the equipment, and then you have a distance site. So your presenting site is the site where the patient would actually go to, which in this situation would be a county health department or a school. The medical cart is pretty much what the patient will be presented on. That is an actual telemedicine cart in one of our clinics. It kind of rolls, looks like a little robot, has a monitor, a couple different scopes and peripherals, and then with a nurse presenting. And then at the distance site is where the provider would be. Just to give you an overview of some of our projects so you understand kind of how we came into this, we have a couple high-risk OB clinics where we use with our centering pregnancy model, where we have ultrasounds and colposcopies, and we consult in Albany with a maternal fetal medicine specialist in Atlanta, Dr. Ann Patterson. So that's going on in 1 or 2 of our clinics. We also use it day-to-day for WIC Nutrition and Education through our Women, Infant, and Children formula program. And they do a lot of nutrition education, breastfeeding support, breastfeeding boot camps. They do one-on-one consultation, lactation support. We also do a lot of staff training and professional development. We also do a lot of vendor relation training. So some of our vendors can all go to our health departments and receive training at once on different food packages, what's allowable foods, what formulas have changed, what's allowed, what's not allowed. So we use it a lot for client services, but also staff training and professional development through WIC. Our children's medical services probably uses it the most. Again, our CMS program sees children with developmental needs, genetics needs. They have endocrinology, nephrology, pulmonology. We have sickle cell clinics. So a lot of those specialty care clinics where, let's say, for example, children in Valdosta need to be seen by a specialist at Children's, and we know the 4.5-hour commute, depending on a day like today, it can take you 2.5 hours like it took me to get from Gwinnett here, is probably not feasible for a lot of these families. So we do have those connections in our very rural locations where they're able to maybe come up once a year, see that doctor in person, and all the follow-up visits take precedent and happen in our local county health departments with their families. So mothers come in, bring their children, they're seen on the video screen, and then consult back and forth with their doctors. We also use it a lot for our infectious disease program with our highly immunocompromised HIV patients. We sometimes do some home health monitoring for some of those patients who can't come to a health department. We'll send out one of our staff. They'll connect with them on video depending on how the internet connection is and if they're not in too far of a rural location, and connect them back with our infectious disease doctor for services. So then we thought about how can we take this a step further? We've been very involved with school-based health centers. We know that telehealth and telemedicine is kind of taking over this way of healthcare, but we wanted to see where our public health niche was. But we knew that behavioral health and mental health was a little bit outside of the public health scope, but we knew that through public health, having telehealth and telemedicine, having the equipment and having the relationships that we do as a state agency, we could probably lead and spearhead an initiative with a school-based health center with support from our partners to see how creative we could be in using this technology with a system of care and looking at a school system where we integrate all state programs into one initiative. As we were looking at expanding our public health telemedicine programs, we kept hearing a lot about school-based health centers. And do school-based health centers have nurses, or don't they have nurses? Do they have telemedicine equipment, or don't they have telemedicine equipment? Are they using it, and aren't they using it? And then when looking at it was, is it sustainable, and was it feasible? So we thought and looked at Lamar County as a very special, specific niche. And when you see, Lamar County is like they're kind of a community school setting. They're located in Barnesville, but they have preschool through 12th grade, their elementary school, their primary school, their middle school, and their high school are all kind of within a little circle radius. They're all pretty much walkable per se, less than a mile walk all through the middle. So technically you could walk around all 3 schools in about 30 minutes and kind of walk your way there. So we knew everything was already very centralized. We already knew that there were other initiatives around behavioral and mental health taking place there through Project Apex. We also knew that DCH was involved in Project Apex, and DBHDD was involved in Project Apex. We also knew that there was a local community service board, McIntosh Trails, that was located there as well. On top of that, we knew that also partners through Emory, the School-Based Health Alliance, already had a established school-based health center there that they were working on building in that existing community. So we looked at all those and said, well, what can public health contribute? So we looked, and through that school-based health initiative that they've already been working out with Emory, we knew that we had a dedicated public health nurse already working in that school system, providing public health services and referrals for services. So Sherry Farr is our school nurse who was already there and integrated in all 3 of those models to some capacity. So we thought and said, okay, how can we use the behavioral health model and help Project Apex with partnering with DCH, and then looking at voices to kind of help us leverage the constituent side, the needs assessments, the program evaluation, and kind of the momentum of getting everybody on the same page working collectively to push this initiative to the next level. Because we thought, what better place to focus our efforts on than an existing standardized, centralized community who already, 1, loves the idea, already 2, believes in partnerships and collaboration, and 3, has a very great need for care there. So that's kind of what goes to my next slide. And it's probably very hard to see there, but I've kind of walked you through a lot of this already. Is we wanted to look at a multi-agency approach for coordinating resources to achieve that quality access for kids. If we knew the school-based health center was already there through Emory, and they had a public health nurse that was leading the efforts, was already providing annual well checks, was already exploring different partnerships with local pediatricians to referral in to see kids at school in a school setting, we were already looking at program evaluation across the board, but we knew that Project Apex through DBHTD was already there, and they were working with the local community service board. It was right down the street. While it was right down the street, it wasn't as convenient for parents to get there. Parents were having a hard time going to the school for services and then also going to that CSB, so the appointments were being missed. We also knew that they had on-site mental and behavioral health intervention by licensed therapists there at that CSB and consultations. So we thought, well, why don't we pilot a telemental health pilot in the school system using a public health nurse? We already had the nurse. Public health already has the equipment, so we were willing to kind of put that out there and try it. And that nurse could present technically the students working with that Project Apex consultant or nurse or staff, whoever that they have there, and have those consultations take place at the school, since parents were mostly already dropping off the kids for school or were coming in for parent-teacher conferences. Let's have those appointments take place in a school so that they don't have to go back to that community service board. Even though it's probably 1.5 miles away from the school, a lot of those parents were not going to take those kids to those appointments, and they were missing those appointments. So if they were already at the school, just like in a health department, let's go ahead and take advantage of them being there. So what have we done in the past year? We worked with all the partners that I mentioned to you today. We developed a procedures manual specifically for school-based telemedicine initiatives for public health nurses. So there are general telemedicine manuals across the nation through the American Telemedicine Association. Some of our partners have developed their own telemedicine manuals for school settings, but we developed one specifically for a public health nurse that is integrated into a school setting, because we know that is a little different. Some schools have public health nurses and some schools have DOE nurses, and they're very different and they have very different functions. So we made sure that our public health nurses had manuals that would allow them to serve patients in school settings, these students. We also then public health installed equipment. So my team went out to McIntosh, went to the CSB with our partners, met with them, showed them how to use the technology. We gave them licenses to our technology. We also worked with the local school and the school nurse to make sure that their equipment was tested and trained and that they were all familiar with how to use the telehealth equipment. And then we worked back and forth, tested and trained them on how to use that. Then we started working through Project Apex to come up with referrals and a communication process developed for the personnel, not only at the CSB, but also at the school nurse, and the therapist. So everybody was speaking one language when it came to enrollment. So you could enroll through Project Apex, but you could also check an extra box if you wanted to do your consultations via telemedicine. And that was explained through Project Apex and through a public health nurse. Then we did ongoing enrollment through the school system. So it took us probably 6 months just to strategize this. And then when school started in August, we sent out kind of permission slips, per se. They went out along with the school enrollment packets. So when Project Apex was doing their recruiting, they included a form on there that said, this will be available not only through our local CSB, but you could also receive the service in your school setting through telemedicine as a partnership with DPH. And that's kind of how our enrollment process went in. You know, this year school started a little bit earlier. We know that school takes some time for these teachers, the faculty, and our public health nurses to get acclimated, get through all their other initial, asthma treatments, everything they have, setting up all their students on a regimen. So we went in about September, did the training, and then in October, November, we started piloting this with just 1 or 2 little patients here and there just to see how it would work, get it scheduled also with the parents. It's important to know that Project Apex in that county right now, when we started, had approximately 40 students only enrolled through Project Apex, and the goal was to continue to increase that throughout the year. I think their goal might have been 65, and I know they were very close to meeting it. So our goal is to kind of continue to help them push that. We know that in those past 3 months, we did 3 different tests. We practiced already. The first one took place in October. It was a half-a-day clinic. We decided the clinics will be once a week, half a day every other week. Again, 40 doesn't seem like a large number. The first year we want to just test it out, work out the kinks, make sure it's actually successful, and move forward from there. We did do that first initial test, and we'll talk to you a little bit about some challenges that we faced along the way. But keeping in mind that this is a small scale, but all the resources are already there, so you can see a successful pilot. The funding was really interesting. You think, well, telemedicine doesn't seem to be a very cheap thing, but when you have all the partners at the table, you'll be very surprised to see how many resources people already have that they can contribute to it. So we pretty much had in-kind donations and grants that were the primary revenue for the startup. So if you look at it, the school already had a public health nurse. We also had DBHDD who had grants that they sent out to community service boards to increase participation and to help them build and expand these initiatives. So that CSB had already received funding for DCH to work and expand Project Apex. We had in-kind donation from the school who always gives you a dedicated space for telehealth and telemedicine. And then public health, of course, provided the equipment as an in-kind donation, pretty much supporting our public health nurses and helping her get the work done that she needed. And then the grant that was received by the school and that local community from partners from Emory for that school-based health initiative. So we spent no money in building this at all. It really shows you those collaborations and people not duplicating efforts, but really making a one-time impact and actually trying to focus their attention on one area. Another thing we started thinking about was sustainability. Well, how are we going to be able to sustain this moving forward? Can we bill for services? And that's really been kind of what's taken the past 3 months to get done. And we only took 1 or 2 patients at a time because we wanted to make sure that we were able to have the consultation, bill for the consultation, and then receive that payment back. And I'm happy to report that when we billed for Medicaid, those last 2 patients, we were able to receive billing on both ends, not only from a public health nurse side, but also from the Project Apex billing side. So that was very successful. We're really excited about that. And you think that may be a tedious task, but any of you who have ever done the billing, you know that's not an easy task. And you sit there crossing your fingers and hoping that you'll get reimbursed for a service that you provide. So we are happy to report that that was a billable service. And this will pretty much kind of help lead and guide us to full throttle starting this new year in this school system. Couple challenges that we face are pretty much just the whole process of enrolling as a provider on insurance panels. The process that it takes a provider to enroll is a little extreme, a little intense, and takes a lot of time. Also, the impact on the lapse of Medicaid coverage for students. So you can be on it for 1 minute, you can get dropped, and then the time to resubmit the application, turn it back around. Kids can go without insurance for an extended period of time where they're not receiving services. And if they're not receiving services or eligible for services, if they go in for something, they're going to have to come out of pocket. So people just pretty much fall off the bandwagon. And then you have to start the process all over. So some students can't get their services or prescriptions. So if you're not enrolled, you don't have a prescription, your kid's not on their behavioral meds, you're wondering what's going on with this kid for 3 months, they're acting out, they're going to the principal, they're going to ISS, all this different stuff. But what the big picture could be is that they had a lapse in their Medicaid coverage and they're not eligible and they can't go into a clinic to see anybody because the lapse is so huge and it's taken so long to get them re-enrolled. So that is something that we're working with Voices and a lot of other partners to really take a look at and see kind of what that lapse, how we can fix that lapse if there's anything that can happen intermediary and how we can move forward with that. Also, just the psychiatry visit as a whole requires a patient or a student to still be present. The parent has to be present for those visits. So that's also a hurdle that we're working on fixing and kind of understanding better. Best practices really encourages, if we're dealing with these elementary, primary, middle school students, to have a parent present. So also adherence is very integral, and it really shows an impact when the parent's not there, because while the kid's in school, that's great. We have the equipment, we can see them, the nurse is there, but if the parent still doesn't come to that appointment, that's children that we're continuing to miss. But we know the importance of having a parent there. So we're trying to get creative with our hours. We're trying to look around when the parents are already going to the school for stuff and kind of tweaking and working on our public health nursing model to make sure that we can still present those patients and see those children with a parent there. But again, we know the challenges that those parents face in getting there. Again, the technology is also very limited, so you're at a school, the parents couldn't be at work, the kid at school, and then the doctor somewhere else. In order to keep that quality, that high quality of care that the composite board expects us to have, we keep our equipment very tight and secure, so we can't connect a parent on Skype, integrate them from their work into our network and kind of do it that way. We've thought about it, but just to keep that standard practice of care and make sure that, just like the medical composite board says, any services have to be at the level of quality as an in-person or greater, then we prefer to make sure that the families come to our health departments for those services. So again, lastly, we're pretty much just looking at aligning program evaluation across the board. So we have not forgotten about the program evaluation piece since we're still in year one and it's the early phases. Along all three different sectors, we're looking at evaluation and considering evaluation tools to measure success. So that'll be something I'll be happy to report on next round, is kind of what the success looks like, what we're doing to evaluate, what tweaks we've made, and what models of care we're going along the way. And we're really leading this and working on this specifically with Georgia, Voices for Georgia's Children, who's leading the evaluation effort for us. So we're really excited about those outcomes and progress. And that's my update for now. Does anybody have any questions for me?
Thank you.
Thank you.
Just very creative, and I know I've participated in some of the school health conversations, and it would be great. I'm on the team, so let's see what we can do.
Thank you.
Okay, let's see. Representative Chandler.
May I ask you one question, please? You mentioned quite extensively Project Apex and that working as part of telemedicine. Tell me a little bit more about how that works in a school,
So
please.
Project Apex has been kind of a referral source where they've been doing a lot of behavior and mental health consultations, and they do a lot of the training, and they also see a lot of the patients. It's been DCH-led. It's funding that DCH sends to these community service boards to see patients and increase adherence and kind of help them build the enrollment, because we know there is such a need for behavioral and mental health across the state of Georgia. So through Project Apex is what they call it. It's a special initiative where these providers are going into school settings and seeing students one-on-one. They'll pretty much pull them out of the classroom. They'll have a one-on-one consultation with them. They'll do their vitals, their weight. They'll talk to them. They'll do everything, and all their consultations will take place in the school setting. So it's really just us adding that additional doctor and that specialty physician, instead of them having them go see them in the school setting and then refer them back to that doctor, that behavioral health psychiatrist for meds, et cetera. Instead of having that third step where they have to go back to their clinic, we're pretty much bringing that doctor into the school. That's how we're integrating with Project Apex.
So the nurse in the school is aware of the mental health issues, and that nurse has extensive training in recognizing those mental health issues.
So they've already been assessed, they've already been diagnosed. These students have already gone into that psychiatrist's office and been seen.
Okay.
It's follow-up. It's follow-up appointments that they're going to be seen back and forth with a public health nurse. So the public health nurse will pretty much present a patient like today. They'll set up the monitor, they'll set up the screen, and they'll say, today I present to you Dr. Katner with patient X, and then they can continue their consultation back and forth with the parent. So they're pretty much just kind of the liaison in between those two, the provider and the family with the students.
So it's not being done for an initial
Not an initial
diagnosis.
visit, no ma'am. It's follow-up services. That initial diagnosis is taking place at the practice, and they're coming for follow-up care. Great question. Any other questions?
Representative Kelly.
Thank you, Madam Chair, and I want to apologize for my lateness to the meeting today.
We all struggled to get here today. The weather was a blessing, though.
Thank God for the rain. Like you, I'm a believer in using our school systems to help facilitate different healthcare solutions. I think it's certainly an avenue for mental health. And I believe that, but I want to make sure, are we documenting a couple things like having the follow-ups available during using a school system and how often they're being used now versus missed appointments outside of that, or is there a way to track that? I mean, I know we're in an initial stage here, but is there a way to track the efficiency of this?
That is something that we have started to track. So we've asked Project Apex and McIntosh Trail to track pretty much their follow-up visits, the number of patients that they see there in their clinic. And then we've also asked them to track the number of patients that have been scheduled and actually seen through telehealth and telemedicine. So we're able to go back and see that follow-up. Did they miss a visit? Were they adherent? If not, what happened? So we like to call, and Sherry mentioned that she'd be calling back and saying, okay, well, you missed your appointment today. Why did you miss it? And maybe they'd say, my mom couldn't get off work, or the mom will say, I couldn't get off work. And we're trying to noting that. Again, we've only seen 3 so far just because we wanted to make sure we could actually bill for the service, but that is something that we're tracking.
And another thing, I think that, so many times students' performance in school is affected by outside influences, and this would certainly be one of those. Are we going to take steps to measure the improvement of the student academically, getting these services on a regular, consistent basis?
That is something we've asked. I was talking to Erica, and I think that was something we mentioned in our meeting last time. She specifically said she'd like to see absenteeism rates. She'd like to see ISS rates and see who has suspension rates, school overall rates, and improvements. So that is something that we're going to try to work with DOE to see what we can do in that local school to make sure we can pull those records. But we'd love to use that as part of our evaluation.
And I'm sure y'all bring it to us at the appropriate time, but do you know right now what we can do as legislators to help facilitate the growth of programs like these in other parts of the state?
So right now my ask would be to really focus on making sure that there is adequate nursing staff to be able to support something like this. I think that's
nursing
our number.
Staff in the school system?
In the school system, correct. It has to be an integrated model. We know that our public health nurses and our school nurses are already being stretched so thin and being asked to do so much with so little time and so little funding. Right now the focus is to make sure that if you initiate something like this in a school setting, that you have a dedicated public health nurse or a nurse in general to help lead these efforts, and that this is pretty much a focus priority for them. So definitely funding for public health nurses, and also funding for telehealth in general through public health. Again, we are one of those specialty pockets where we're able to provide this service in a school because we have public health nurses already at this school. Public health wouldn't be able to provide this service if it was a separate kind of nurse or a DOE nurse. We wouldn't be able to as easily get into that school system to provide the service using our equipment because we're not physically there.
So if in my school system we just have the nurses that are employed through my local school system, that creates a problem for us here. It would be beneficial for programs like this to have that nurse be an employee of Department of Public Health instead of the school system.
To some capacity, yes, or at least have one of your nurses dedicated to telehealth and telemedicine, because the clientele is totally different. You have to have a lot of follow-up. You have to have records, and they have to have the time. It has to be scheduled timed appointments back with these specialty providers. If you just use your existing nurse, I'm not saying it won't work. It'll just stretch them very thin because the time it takes for a consultation such as this is just like a regular in-person visit. It could be a 30 to 40-minute consultation back with that doctor, which would then probably pull away from whatever other services those nurses are providing.
Do we know the population of children here? Or largely, is there funding for their services through state Medicaid, or are these students who are on private insurance? Do we have a mix of this? Or
it's a very good mix, especially in Lamar County. We've seen everything. We've seen private paid. We've seen a large number of them are mostly Medicaid, yes. But there is some private pay insurance patients as well.
Okay. Thank you so much.
Thank you. Have a great day.
Okay, I don't see any other questions, but thank you. That was a great look into what I hope will be a great example for the rest of us as we move forward in addressing the concerns. Okay, next from DOE, Gary McGivney, the Deputy Superintendent of External Affairs and Policy and a true dedicated expert in this arena. Thank you. Thank you for being here.
Good morning, everyone.
Oops. Good morning.
Thank you for the opportunity to be here today, and thank you for the invitation to be here today. If I may, Madam Chair, I'm going to dispense with any kind of preamble and just get to the report, but I would like to divide it into 5 sections, and you have the report in front of you. One will be the children's mental health data, children's mental health school intervention and prevention, children's mental health and adult outcomes, adult mental health and children outcomes, the mental health workforce, and then of course, some recommendations. I've included in the report you have references, and I hope you'll bear with me because there are 105 references. I'm not going to read the references because I know you don't have time for that, obviously, but those references are there to indicate and provide for you in case you want to follow up with those references. And in the final report, I know sometimes you have references. And when I speak to individuals and groups around the state, which I've been asked to do a lot more of that recently because there's growing interest in children's mental health around the state and not just in school systems. Of course, I speak to school systems a lot, but also the request for presentations now is coming from Rotary clubs, advocacy groups, public health groups, a number of other entities that in the years past we haven't really heard from as far as children's mental health. But let me go through some of the data, because when I speak to these groups, it's somewhat surprising to me how little they understand about the prevalence of mental health issues in children. 1 out of 5 children birthed to 18 years of age has a diagnosable mental health disorder. Symptoms of depression and anxiety, post-traumatic stress disorder, and other mental health issues can begin to manifest in infancy and toddlerhood. 15.4% of children ages 2 to 8 years have at least one diagnosed mental, behavioral, or developmental disability. Between 9.5 and 14.2% of birth to 5-year-old children experience significant social-emotional problems that negatively impact their functioning, development, and school readiness. Increasing numbers of young children are being expelled from child care settings, which, by the way, the expulsion rate in child care settings is higher than the expulsion rate for K-12 education, can be reduced with mental health consultation. In fact, a recent study by Yale showed that reduction can be as high as 47%. 1 out of 10 children has serious mental health problems that are severe enough to impair how they function at home, at school, or in the community. The onset of major mental illness problems may occur as early as 7 to 11 years of age. Almost 50% of all long-term mental health problems start by the age of 14. 14% of children with mental health problems receive mostly D's and F's in schoolwork. Consequently, 44% of children with mental health problems drop out of high school. And I should point out that the data that I've spoken about so far as outcomes addresses primarily untreated mental health problems. In the course of the school year, many children with mental health problems, again untreated, miss as many as 18 to 22 days of school. Now, that doesn't include if they have a cold or if they get the flu. Then you can add those days to it, would typically be 5 to 10 more days. So now you're talking about almost 2 months out of school. And our research at the Department of Education found out that learning is impacted after only the 6th day of absence. Students with unmet mental health needs can be a significant obstacle to student academic career, social-emotional development, and can even compromise school safety. 32% of children, and this is a segment of the population we don't hear too much about, 32% of children in military families scored as high risk for mental health problems, which is 2.5 times higher than the national average. And also keep in mind, in Georgia, we have at least 30,000 school military-connected children in schools. That's a conservative number. It probably is closer to 35,000 because there's so much mobility. There's a higher prevalence of mental health problems in youth age 11 to 17 in military families compared to the general population. Only 45% of adolescents, young adults who were hospitalized for a suicide attempt received any mental health services in the prior month. Only 29% of children expressing suicide ideation in the prior year received any type of mental health services. Mental health indicators from the REACH study. We embedded those 12 questions in the Georgia Student Health Survey, which was administered to over 600,000 students in middle and high school. It's an anonymous survey. and these are some of the results of the survey. The number of students who considered harming themselves more than 5 times, 43,435, that's 7%. The number of students who attempted to harm themselves more than once is almost 45,000. The number of students who on more than 5 occasions experienced drastic changes in behavior or personality, almost 54,000. And I hate to read the next bullet to you. 70 to 80% of children in need of mental health services do not receive any therapeutic support. In a survey of school social workers, only 11% of respondents reported all or most students on their caseload received any mental health services outside of school. Now, concerning children's mental health and school intervention and prevention, the research shows that schools are often one of the first places where mental health crisis and mental health needs of students are recognized and initially addressed. Of school-age children who receive any mental health services, 70 to 80% of them receive that at school. Now that says mental health services, it doesn't say therapeutic services. As we know, school counselors and school psychologists and school social workers are not therapists. So when we talk about the mental health services at school, seldom is that the therapeutic services. I'm a school psychologist and my doctorate is in school psychology, but we were not trained as therapists as they would receive in therapeutic services with a clinical psychologist or psychiatrist. An unstable, non-supportive, non-responsive school climate can exacerbate the conditions of students with mental health problems. Interventions to improve school climate promote the emotional and behavioral well-being of children and adolescents, particularly ones with mental or physical health problems. School climate affects not only students' motivation and school satisfaction, but their academic progress, their health, their mental health, and the quality of life as well. And these findings are consistent with research indicating that the school's climate affects a broad range of student emotional and behavioral outcomes. Interventions to improve school climate promote the emotional and behavioral well-being of children and adolescents, particularly ones with mental health issues. Research over time shows that the mental health status of students worsened if the conditions of the school climate did not improve. A meta-analysis indicated that students' perception of the 6 dimensions of school climate were found to be significant indicators of their mental health. The importance of viewing school climate as a prevention concept is supported by research that looked at the challenges to school safety when students did not feel that the school climate includes positive relationships between students and staff members. And there exists a preponderance of evidence to support the implementation of positive behavior interventions and supports as a research framework for improving school climate. What the research is also showing is if you implement PBS and improve school climate, you've also created a good model for school-based mental health programs to improve children's outcomes. Implementation of PBS has positive outcomes at the school-wide level, but also allows staff to focus on the needs of individual students as well. We have found that when you stabilize the school climate, other preventions and intervention programs are more likely to be effective. The Georgia Department of Education has increased the number of schools implementing PBS from less than 100 in 2009 to over 800 in 2016. One of the major pillars of the Georgia Department of Education strategic plan is now school climate for the first time in the history of the Department of Education. It only took 100 years. Georgia schools implementing PBIS, and this goes to the question about the research, schools implementing PBS have an average CCRPI score almost 25 points higher than schools not implementing PBS. Also, schools that implementing PBS have a much higher school climate rating. It's almost 90% of them have a school climate rating of 4 or 5 on a scale of 1 to 5. To augment the critical element of school climate around classroom engagement, the department works with the Marcus Center to provide social-emotional engagement, knowledge, and skills to almost 30 school districts. This provides 24 focused, evidence-based instructional strategies to focus on the interaction between students and staff. However, educators, and this was brought up earlier, educators need training on how to identify students with possible mental health issues and to better understand mental illness. One of the most effective methods in the research shows that providing this level of awareness is through youth mental health first aid training. Research demonstrates that youth mental health first aid training increases participants' knowledge regarding mental health, decreases their negative attitudes about mental health, and increases supportive behavior toward youth with mental health problems. This increased knowledge leads to more appropriate referrals for services. What we've seen in those schools that are implementing the youth mental health first aid training, as well as PBIS to improve school climate, the referrals that normally in the past would go to the discipline office are now going to the counseling office. So the out-of-school suspensions are going down. Project AWARE, which stands for Advancing Wellness and Resilience in Education, it's a federal grant that Georgia received, is earmarked for Muskogee County, Newton County, and Griffin-Spalding County to implement the training in youth mental health first aid, as well as provide training on how to make appropriate referrals. Georgia, through that grant, has trained 966 educators on youth mental health first aid training. Those who were trained have made 4,447 referrals for students for assessment services. Over 700 students have received school-based mental health services, primarily through the interface with Georgia Apex project, with another 400 students being referred to community-based mental health services. In schools with the combination of PBIS, Project AWARE, and the Apex project have seen substantial reductions in out-of-school suspensions and corresponding increases in academic outcomes. It's a model of combination and cobbling. However, the challenge, however, is Project Apex is not in the regular budget, nor is Project AWARE. Those are short-term grant projects. The PBIS, we depend a lot on federal money through special education to support the staff for that. We did receive and have received for the last 3 years supplemental money from the legislature and from the governor's office for PBS training. But the combination of those three is proven to be very effective. Project Apex is a pilot program, as you've heard, to build infrastructure and increase access to mental health services of school-age youth throughout the state. Project AWARE and Apex work together on the prevention, intervention, and treatment continuum. Suicide's on that prevention, intervention, treatment continuum. The 2015 General Assembly passed House Bill 198, sponsored by Representative Katie Dempsey, known as the Jason Flatt Act. Since the passage of House Bill 198, the following actions have been taken. The Georgia State Board of Education created State Board Rule. The department developed a suicide prevention model policy. The DOE worked with experts in the field to develop a training curriculum, trainer's manual, training videos, training materials, and training evaluations. The DOE trained over 1,000 trained the trainers the first year, and now the annual training is provided in every school district, and each local board of education has a suicide prevention policy. The DOE also, with help from experts, developed a prevention suicide toolkit for schools, developed a suicide prevention resource list for schools, created a web page with the bill, training materials, and other information, including video training that's available to schools at any time. Also, just want to mention that school counselors respond to the need of mental health and behavioral prevention, early intervention, and crisis services that promotes psychosocial wellness and development for all students. We also have school psychologists that consult with school staff and parents and service providers regarding mental health needs of children. We have school social workers that have special expertise in understanding the family and community systems as well as individual student needs. And school nurses, who often are the first ones to indicate or find that a student has a mental health need. A recent study showed that 33% of a school nurse's time is spent on mental health issues at schools. And I'm going to talk about workforce in just a moment. I know this committee is focused on a lot of adult outcomes as far as mental illness, but I also want to mention children mental health and adult outcomes. The Adverse Childhood Experience Study identified the relationship between adverse childhood experiences and mental and physical illness in adults. Children and teenagers with psychiatric disorders have 6 times higher odds of having health, legal, financial, and social problems as adults if left untreated. 6 times higher. Studies show mental health problems during childhood that are left untreated make it more likely that the child later as an adult will be arrested. Research shows that mental health problems in children are significant and can have long-term effects. Children continue to have problems in adulthood if untreated. Ben Leahy, who is a distinguished professor of epidemiology at the University of Chicago, said that we don't invest enough in children's mental health treatment to reduce the negative outcomes in adulthood. The effects of untreated children's mental illness is steady and often rapid decline in mental health. Mental illness will not go away on its own, and the longer it persists, the harder it is to treat and the more serious the outcomes. Early identification of mental health problems and providing intervention improves outcomes for children before these conditions become far more worse, more costly, and more difficult to treat. You may not know this, but 70% of our youth in state and local juvenile justice systems have a diagnosable mental illness. Youth with mental and emotional and behavioral disorders that are not appropriately treated are more likely to use alcohol and drugs and be incarcerated during their adult years. Early treatment of mental illness may be the difference for some children between a lifelong disability with possible incarceration and dependence or a healthy measure of economic and personal self-sufficiency. But it works the other way as well. Adult mental illness and children outcomes. The importance of mental illness treatment for adults can impact children. Results of research indicates that persistent maternal depression predicts more negative behaviors, smaller achievement gains, increased school absences for students in kindergarten and elementary school. Again, that's mental illness that's untreated. Diagnosis of untreated parental mental illness through a child's life was associated in research with worse school performance through school and all the way up to age 16. Research shows that children who have a parent with a mental illness that is untreated are at significantly greater risk for multiple psychosocial problems and academic failure. Children of parents with untreated mental illness are more likely to show developmental delays, lower academic competence, and difficulty in social relationships. A long-term study over a 40-year period of time, research results support the view that untreated parent mental illness is a risk factor for children. The workforce, you'll see that page there. I won't read all this to you, but you can see the workforce challenge in Georgia, the number of psychiatrists, and some of those psychiatrists do not treat children under the age of 18. And that ratio is 1 to 2,380. And we're talking about basing that on school-age children. Psychologists, the ratio is 1 to 781. But again, many of them do not treat children. You can go through the list there. The school counselors, the ratio is 1 to 450. And in Georgia, it's 1 to 500. Well, that sounds like we're really close. And then that's one of the categories where we are pretty close. But what that means is that's 400, almost 500 more counselors would have to be hired to meet that ratio. School psychologists, the ratio recommended is 1 to 1,000. We're at 1 to 2,260. And that's not a typo with the social workers. We have about 600 social workers, and the recommended ratio is 1 to 250. Our ratio is 1 to 2,266. And keep in mind, too, as I go through this, what I said earlier, that most of the children who receive any type of mental health services, they receive them where? At school. And I added this note, if you'll see on that page, because it is tied to the workforce, of students receiving outpatient care for mental health conditions, 35% receive mental health services from the pediatric primary care physician and not from a psychiatrist or a clinical psychologist. That's why the pediatricians, one of the top requests for supplemental education from pediatricians is in the area of children's mental health. So we're to the recommendations. It's recommended the state develop a Georgia Children's Mental Health Strategic Plan and the infrastructure necessary to provide comprehensive, accessible, and coordinated mental health prevention, early and timely interventions, and appropriate treatment services for children from birth to age 21. The plan should be fully developed by the creation of the Children's Mental Health Reform Council. Arguably one of the most effective pieces of legislation in the last 20 years was the development of the Criminal Justice Reform Council. I'm suggesting that we use that as model legislation to create a Children's Mental Health Reform Council. And this is just my opinion. This is not the DOE's opinion. I don't think one state agency can possibly do what has to be done. To expect BHDD to do this is impossible. There's too many pieces. There's too many moving parts. There's too many needs. It's too complex for one agency to be expected to do this. The power of the Criminal Justice Reform Council has been the people that are put on the council. They're problem solvers. If an issue comes up, the council solves the problem. They look for experts in that area and they resolve the problems. The plan that I'm talking about, the comprehensive plan, should contain the following elements, plus other measures as needed. There will be an annual recommendation for the state budget for children's access to mental health prevention, early intervention, and timely interventions and treatment. Develop as part of the plan a Georgia Mental Health Workforce and Development Plan that puts all of the providers together. As legislators, I don't know how you manage it when you have one group come before you and say, we want you to fund more school counselors, and another group comes before you and say, we want you to fund more public school or public nurses, and another group comes before you and says, we want you to fund more psychologists. As a legislator, I don't know how you decide which group you're going to fund and which group you're not going to fund. So we're suggesting that in the comprehensive plan, you put the workforce group together. So it's a comprehensive approach to the workforce problem. Reduce the ratio of students to mental health personnel in Georgia schools, including the school psychologists and what we talked about earlier. For mental health workforce development incentives, offer students studying psychiatry or psychology loan forgiveness in exchange for committed time, say 3 to 5 years working in Georgia. Other states have done this. Develop a community psychiatry fellowship program with a public-private partnership with universities. You can look at the New York Columbia University model or the Connecticut Yale University model or the Texas University of Texas Southwestern model. Support the development of a state sustainability plan for Project Aware. We know it works. We have the data that shows that it works. But the grant's going to end in a couple of years. And then what are we going to do? Look back a couple of 3 or 4 years from now and say, I wonder what happened to Project Aware. That seemed to be working very well. It's time for the state to develop a sustainability plan for those programs and interventions that work. Support the development of a state sustainability plan for Georgia Apex project. Again, we know it works. Why not have it part of the annual budget for children's mental health and not wait for that money to run out or that project period to run out? Broaden access to health care and mental health services in schools and child care centers by expanding school-based services. A good example of that is in Connecticut. They include mental health consultations for schools and centers statewide in Connecticut. Broaden access to health care and mental health services in schools and child care centers by expanding telemedicine and telemental health services, and include coordination with care management organizations. Expand mental health training and consultation of pediatric primary care physicians to provide mental health services for children. And you can see there, one example is the District of Columbia Collaborative for Mental Health and Pediatric Care. It was developed to assist primary care pediatricians to learn more about children's mental health and to provide resources for the pediatricians. One of the first things they did was provide a resource list for pediatricians. When they found out that 35% of the pediatricians did not have access, they did not know where mental health services could be provided or could be found. Develop a clearinghouse of children's mental health research, mental health endorsements, and best practices. Expand language, nutrition, and early brain development awareness and training through preparation and continuing education programs for nurses, nutritionists, physicians, early childhood educators, and teachers. Expand PBIS. We know it works, but we're having a capacity issue now. We also know that for children, it works for all children because it improves the school climate. But for those kids who have special needs, could be long-term needs or situational needs, it benefits them the most. Support inclusion of early childhood classroom practices as part of PBS training. We put PBS training in preschools and child care centers, and it works there as well. Support the development of state sustainability plan for the clubhouse services through BHCD to preserve prevention, intervention, post-treatment resources for youth. You remember the old Title IV Safe and Drug-Free Schools grant we used to get from the federal government? Georgia used to receive $6 million for substance use and abuse education. Guess how much we receive now? 0. And schools are struggling to try to find the resources to get back to that level of implementation of substance abuse and alcohol education. Implement screening, brief intervention, and referral to treatment programs and training programs to address youth substance abuse. And finally, develop partnership of facility uses so that we have cross-functional training opportunities in all the locations that you see in that list there. I want to point out, Madam Chair and other members of the committee, of those 19 recommendations, 15 of those come from previous House and Senate study committees on mental health. The need is great, the timing is right, and the will is strong to do something about children's mental health. Thank you, ma'am.
Thank you, Dr. McGivney. As always, you've given us a great framework to work from, too. And I really appreciate the time and effort and resources that have gone into this, but as well the combination of so many factors that I think we have worked on, continue to work on, and need to pull together even more. So thank you for highlighting that. We've got some questions for you. Let's start, first of all, with Representative Chandler.
Thank you, Dr. McGivney. And you gave us so much information that I was having a hard time thinking about all of it because I was wanting to think a little bit more before I moved to the next item. So my questions may be something you've already said, but bear with me. First of all, and I have several, Madam Chairman, if
Please.
it's all right. First of all, you mentioned the, I think, critical amount of young people in military families that have mental health issues. In our base schools around the state, or in the schools in the area around our bases, do we have any additional resources in mental health for these young people?
There are some additional resources, but that depends on the relationship between the local school system and the community service board, and also the military compact, and George is a member of the military compact. Mm-hmm. They provide school liaison officers, SLOs, for those school systems that have large numbers of military connected students. And they serve primarily as a consultant, primarily as a liaison between the needs of the family and the school system and the services that are provided in the community. So those school systems that have the school liaison officer, they're able to cobble together services, but they frequently contact us wanting to know what other services may be available. Now, what has shown promise, again, is the Project Apex, where the CSB service is brought into the school. And then that combined, even though the federal grant we had for Project Aware for the youth mental health first aid training was primarily for 3 school systems, the grant required us to identify large, middle, and small school system for the grant. We've gone outside of the grant. We're training people outside of those 3 school systems using that grant. It's opened up training to all the school nurses in the state of Georgia, and the school liaison officers now are going through that training as well. So again, I'm not saying that their extra service is enough to meet the needs, but there's a great effort to try to find additional services for those students.
And I don't know all the acronym. What am I trying to say? What's the word? I don't know all the terms and what they mean. But with the training that's being given to teachers and so forth that you just mentioned, that's been very limited, is there any way that could be done, Dr. McGibney, with a trainer of trainer model?
Well, we have trained 1,000 trainers. About 700 trained the trainers. But you have to understand we have 110,000 teachers, and that doesn't include administrators and parapros and all that. But yes, we're trying to figure out ways, and we're have found some avenues of funding to expand that training to more people. What we're finding too, though, interestingly enough, is parents have a great need for training of mental health awareness, particularly those who have children that are having issues and they don't want to accept the fact their child has a mental health need. It's because they just don't have the information, they don't have the background, they don't have the knowledge of what mental health really is. So we're finding that the more we do the training, the more the number of people also need the training and also want to have that awareness as well. Ideally, every teacher would be trained, every administrator would be trained, every school nurse would be trained. Not all of our counselors have gone through the training, not all of our social workers have gone through the training in their professional development, nor have all the school psychologists. The ones who have gone through that training from that cadre of professionals have found it to be even more beneficial than the ones who, teachers for example, because they're working with children who have those needs all the time. Plus it gives them the training and expertise that they then can share with the staffs that they work with on a regular basis.
And one last quick question. I understand the need for in-service training, as it may be, within the school system. But it's been a long time since I went through a teacher education program. What's being done on the college level for folks entering the field of education in mental health education?
I can't speak directly to that.
Okay.
We have encouraged the university system to look at how teachers and administrators are trained, not only with mental health, but also with school climate, classroom discipline, and those other issues that continue to come up on a daily basis in public schools and even in private schools around the state.
Thank you. That looks like an area we need to push a little bit more on. Thank you.
Thank you. Representative Kelly.
Thank you, Madam Chair, and appreciate you being here with us and the range of data that you've given us. I find it extremely helpful, but I'm going to jump around a little bit and maybe see if I can go a little bit deeper to help my understanding of what we're dealing with and what we can do to help address this further. And so the first point I want to talk about is making sure I'm doing some math right here. On page 3, you talk about 1 out of 10 children has serious mental health problems, severe enough to impair how they function at home, in the school, or in the community. So 10% of Georgia students. Then we jump down and we say 44% of children with mental health problems drop out of school. Mm-hmm. So if I'm trying to remember how to correctly add percentages or multiply percentages here, but it looks like approximately 4.5 students out of 100 in Georgia drop out of school because of mental illness. Would that be right?
That's national data, but yes, that would be one way to look at it, yes.
And so Georgia's graduation rate's a little over 78% now. If we cut that number in half, we get over 80%, right?
That's correct.
Okay. We talk about the high percentage of children in military families that are scored as high risk for mental health problems. And in Georgia, that's 2.5 times higher than just children national average. Why is that?
Well, the research, if you look at the reference there, the research, if you go look deep into the research, is because of a number of things. Number one is just the trauma that comes with moving so many times. The average military family, by the time a child's age 16, has already moved 6 to 8 times. And if you've been in school, if you ever had to move from school to school, you understand that in and of itself is pretty traumatic, because you don't really develop a network of friends and your social support network. The other is the number of deployments recently has increased pretty dramatically. At one time, it was pretty rare to have more than 2 deployments. Now it's pretty common to have 3 to 4 deployments. And that's when one or even both parents have been deployed out of the family. And of course, that is pretty traumatic. And then there's a list of other indicators that tie directly back to that 2.5% higher rate.
On page 6, you talk about needing to increase the PBIS program. You talk about how successful it's been. And it's already gone from 100 to 800 schools from 2009 to 2016. What do we need to do to increase that number even more? Because I know we're still only capturing a fraction of the schools in Georgia. What do we need to do to increase the number? And is it just purely funding?
It's not purely funding. Funding would help us increase the capacity to respond to the training. When the school climate rating came out, which was last school year, it put a different spotlight on the importance of school climate. It showed that the legislature was serious about school climate rating because that's in law. Every school in Georgia has to have a school climate rating. It also was paired with the results that we were able to show schools about the correlation between school climate and academic outcomes, school climate and teacher retention, school climate and teacher attendance and student attendance. So with that data plus the school climate rating created the perfect storm where now we're getting so many requests from schools for the training, because it's not off-the-shelf training that you go in and do and then you crank it up the next day. It's very intensive training. It takes a lot of preparation. There's the implementation, there's the introductory stage, there's the implementation stage, and then there's the fidelity stage. And that takes a while, because we're talking about changing the whole culture of the school. You're talking about changing.
How long? What's the timeline on average?
To get to fidelity, we're talking 2 to 3 years. But we have a waiting list of schools now because we have so many schools interested in improving or implementing PBS, because now they see and they're hearing from their colleagues. This has been the genesis of the large increase in requests, is teachers talking to other teachers in other schools, administrators talking to administrators in other schools, saying, we implemented this PBS and I wasn't sure about it, but this actually works. So the word of mouth, and not DOE down, but word of mouth, has really increased the number of schools wanting to implement or have the training in PBS. We have a waiting list. We can't get to them quick enough. So yes, funding would increase our capacity to get to the schools quicker. For those schools that are reluctant about implementing PBS, typically that's going to be a leadership function. Because as the leader goes, the school goes. When a leader is committed to changing the climate of the school, then that's when we have success in the school. But that number, the number of administrators that are not interested very much in that is dwindling pretty quickly.
Do you have a list of schools that are currently in the PBS program? Is that on the website, or could you supplement that to us?
It's on the website, and I can send it to you also.
What is the backlog? How many are on the waiting list, and how long in the current system that you're in would it take just to clear the backlog that you got right now?
If we had the capacity, there'd be 50 other schools that we'd be working with this year. Because it's not school system, it's school-based. But the leadership at the central office, the superintendent has to support it. Because we found out if a superintendent in a school system doesn't support it, then the principal that wants it and supports it is pretty much on an island. So we have to get the commitment, and we do require the commitment from the superintendent central office, and that works best.
I think I'm almost done, Madam Chair, but just maybe one more question. You got a long list of recommendations, and you talked about our competing interests up here that we have to sort through. So if you had 3 things that you could list, what are the top 3 recommendations?
I'll give you one.
Okay.
How about that? One. That there be legislation modeled after the Criminal Justice Reform Council to create the Children's Mental Health Reform Council. That would bring all those other elements together. Because in my opinion, without that mechanism, we're going to be having these hearings every year for the next 5, 6, 7 years.
Thank you. I appreciate the work you do.
Thank you. Representative Alexander.
Thank you for all this great data that you provided. I know mostly what you talked about was intervention programs. What organizations or programs do they have for parents who have a child? Because that's what I'm hearing from our parents that have children that have mental illness, and they're reaching out to all these different resources and doesn't appear to get the help that they need. So what organization, what support services are there for these parents that may be looking for, have an issue with children that do have mental illness and just feel like no one is listening?
Well, the one that's most readily available to them is going to be the Community Service Board throughout the state. However, when we get those calls at the DOE, we refer those calls to United Way because they have the largest list of resources available throughout the state. And then there's many other advocacy groups that you can refer them to, like Voices for Georgia's Children, NAMI, the National Association of Mental Illness. There's a number of advocacy groups that also have a resource list. So if they're not getting the resources, and sometimes it takes an effort and support from others to help a parent find those resources. I'm not saying it's easy. I'm not saying one phone call is going to end up with them getting the resources they need. But my point is this: they can't do it alone very often. It's quite a system to navigate.
Right. One last question. I know you talked about the Legislative Children Mental Health Council. I believe there's a case here in Georgia, and I'm not sure if you know very much about it, about a young person with mental illness that committed a very serious crime. And I believe what the judiciary system is saying, that there is no place to place this individual. So does that mean that person with the mental illness is going to go into an adult facility with other criminals, and they're not going to get the help that they need with their mental illness?
Well,
just a question. I'm not sure if you know much about that case.
Well, no, I don't know anything about that case, and I can't speak to that specific case. But that is the type of situation, it's my understanding, that the Criminal Justice Reform Council addresses. And they have that format has allowed for a lot of problem solving to take place, including substantial improvements in the juvenile justice system in Georgia. It's a good mechanism for putting a lot of the efforts and recommendations together.
Thank you. Representative Gardner.
Thank you very much, Madam Chairwoman, and thank you for the work you continue to do to educate us on the needs of the children in our state. Some of them are sounding familiar, which means maybe they're bubbling up and their time has come. As we look at the workforce issues, I'm always looking at the number of licensed providers we do have in our state, and I wonder if part of the Children's Reform Commission task should be to understand clearly what the barriers are for some of the people who are in our communities. I mean, for example, in Fulton County, where we have nearly 1 million people and no CSB, there are a lot of providers. And the question is, what are the barriers to their being involved in the schools in a more intensive ways? I know the Atlanta Public Schools has embraced the PBIS program and some of the other programs, and that's great. But has anybody really looked at the barriers? Is it about money? Is it about systemic silo building? Or
I think the best way for me to try to answer that is this. I think a lot of state agencies that have direct responsibility for mental health, as well as those who have indirect responsibility for mental health, are doing the best they can within their agency. And they're having those discussions. And there is, there's the Behavioral Health Council, I think that's the name of it, it's in statute. They meet and they talk about a lot of these issues as well. But what type of authority do they have, say as far as appropriations? What kind of authority do they have to convene a meeting that has the problem solvers there who are closest to the problem is debatable. So I think to answer your question, there's a lot of work going on. There's a lot of a will to do better going on. There's a lot of plans that have been laid out. But all that coming together in a sustainable way and a statewide strategic way is what's missing.
Well, I think that Children's Council, Reform Council, would very much help Fulton County, since we have no CSB and we're working on coordinating mental health services, but huge gap for children.
And then one of the things that perhaps that council, if it ever comes to fruition, could address would be the Quitman's County too, where we have 300 students in the entire school system. There's not going to be a psychiatrist to live in Quitman County,
No.
But they have mental health needs.
They sure do. Thank you for all you do for our state.
Sure.
Thank you, Dr. Gibney. Once again, you have brought such great ideas forward, but you also have challenged us to commit to do some of the work that has already been brought forward by previous councils, and I thank you for that. I personally saw, as many of us here did, how quickly you were able to help with that passage of the Jason Flatt Act, and not only just to pass it, but to implement it. It's one of the most expedient and affecting tools I've seen us do while I've been here. It is life-changing, and I personally feel that we can do the same. So thank you for once again giving us some great framework as we get together and talk about what we really want to put forward as our chief goals of this committee. And I know that wherever you go, I know you are affecting lives of children of all ages every day. So thank you for your commitment. Okay, to follow up with that, a perfect follow-up, I think, Polly McKinney and Erica Sitkoff. I'm going to let y'all introduce yourselves specifically, but about Voices for Georgia's Children. And y'all can either sit at the table, we think it's working, or stand, whichever you're most comfortable.
I think we're going to stand.
Okay.
Because we have slides, so. Hi, I'm Polly McKinney. I'm Advocacy Director at Voices for Georgia's Children. I want to thank all of you for allowing us to present on our framework idea. This is my coworker and our Policy Director at Voices, Erica Fenner-Sitkoff, who's also a licensed clinical psychologist and has a brain the size of Texas, which we're very grateful for. And today we can answer questions on an array of things. As many of you know, we work on school-based health a lot at Voices and along with a lot of our partners, but we also work with Erica's big brain, on child and adolescent behavioral health. So we were, just a quick background, we drive around in a car a lot together, and we have all kinds of ideas while we're doing this. And this one idea we had was very similar to ones that we have heard this morning, to condense a lot of the stuff we've been hearing into some things that, should there be a counselor, should there be further work on this subject, which obviously there's a great appetite for now, should be considered as we go forward into talking about child and adolescent behavioral health. So with that, I'm going to step away from the microphone unless there's a crisis and let Erica take over. We have to figure this out, though.
There we go. Should be right here.
Yeah. And then this one for the chalice. Did that. That one. Ah. There we go.
We did it.
That's our first
Success. Oh, thanks, Polly, for those kind words. Thank you, Madam Chairwoman and the committee. As you've heard today, and I'm sure you've been hearing over the last few weeks, there's been such momentum around child and adolescent behavioral health, and it's in large part because of the work that you've been doing and bringing attention to this issue, and our tremendous partners that you heard from today. So we thank you from Voices. So Dr. McGibney provided a great deal of deep data, so I'm not going to go too far into that here. We have some general highlights that you have heard before, that we're not just talking about several thousand children that are impacted by this. It's tens of thousands of children that are impacted by this issue. And when we think of behavioral health, depending on your personal experience, it can mean a wide variety of things. It could be everything from bipolar, suicidality, autism, substance abuse. And so given that comprehensive nature of the issue and the plentiful asks that you get, as Dr. McGibney spoke of, we thought that it would be helpful to chunk that into categories and to illustrate some possible examples that have been talked about in the legislature study committees, in strategic conversations in state agencies, so you can begin to see how it could be helpful to think about that comprehensive and broad scope of an issue. And not only that it's an issue like we've talked about in schools, but it really starts in early childhood from birth, from the impact that parental mental health can have, and in young children. And I say that because in Georgia, the youngest child that took their life, committed suicide, is 8 years old. And last year, the youngest child was 9. And so clearly there are things that we can be doing early on, that we can begin to identify and notice issues early on and intervene. And it's an issue that impacts children at a very young age that we wouldn't necessarily think would. So we are, as Polly stated, in full support of a comprehensive state strategic plan to begin to think about this issue. One that looks at data objectively, that engages the diverse stakeholders, and that relies on strong leadership within the legislature and the executive branch. As we've seen, and as Dr. McGivney stated, we've had such success in reform before in criminal justice, education, and we believe that we can have strong success here if we have that type of strategic plan. Additional, because so many systems work on these issues or touch this issue, that this plan would focus not only on workforce access, but transition between those systems. A concrete plan would help us move from all these multiple conversations into actual actions, and that we would encourage, given all of the different actions that a council could take on, to begin to think about what are those initial few actions that could be done in that first 1 to 2 years that could have a significant impact and instill hope for future change. Because there's so many different asks that come before you, not everyone could necessarily get what they want in that first year for the specific population that has touched their lives or that they're advocating for. But if we can conduct that objective analysis to see what could have the greatest impact and build a foundation for future change, it could be incredibly powerful. And then, of course, work to implement it. So what we did is took the different study committees that have looked at this issue, strategic conversations that have been going on in state agencies like the interagency directors team that reports to the Behavioral Health Coordinating Council, the Governor's Education Reform Commission, the Child Welfare Reform Council that had recommendations as well this past year on children's mental health, and compiled that into 8 different components, and have asked some questions behind those 8 sections to begin to help think and focus and frame how we think about this issue. And I'm not going to read each of these to you, but I'm going to go in and provide some illustrations of what that could look like within each of these. So scaling effective programs. Which programs are effective and how do we expand them? We've heard about Project Aware. There are other programs and pockets throughout the state that we have actual data from Georgia families and Georgia's children that can show that they are successful. And to look at it from an asset perspective of what do we know that works here in Georgia in different communities and figure out how to expand them. And what are the different funding streams that can do that? As Dr. McGivney noted, there are federal grants that do that right now, but there are also other funding streams like Medicaid, other programs that can help sustain them over time. Are there any policy or logistical barriers that we can work to overcome those? And cultural barriers, take a look at those. Project Apex is another one that we've taken a look at. Representative Gardner, you mentioned the work that's being done in Atlanta Public Schools. They've looked at a private-public partnership model where they've taken community providers and developed contracts with those and assigned them to different regions of the schools to have a direct referral resource. So there's some very innovative models in addition to Project Aware, Project Apex, that some communities are partaking in. Judge Walker in Columbus has a program around parent-child interaction therapy that looks at very young children, birth to 5, to see how to work with parents and children together to strengthen their relationships. That has been incredibly effective. So how do we work to bring that to scale? The second category is workforce development. But that isn't just about growing the workforce here. It's also about how do we maximize the licensed providers that we do have in our state to reach further through telemedicine or consultation practices. How do we make sure that once providers are trained here, that they stay here for their licensure, that we incentivize for them to supervise and keep people here so that they are they want to stay and work in Georgia. Right now, certain training facilities can't get reimbursed for the services that their trainees provide. If a psychiatrist is in residency or a psychologist is in their training year, they can't get reimbursed for those services. So it's hard for them to fiscally sustain providing that supervision and graduating licensed providers here. So it's something for us to consider. Loan forgiveness, as we've talked about. What's the balance that's needed behind certified versus licensed professionals? There is an incredible program out of DBHTD, the certified peer support specialist, both parent and youth level, that is incredibly effective. So what does that look like to bring that across the state? And how do we balance that with needing licensed professionals? How do we sustain it fiscally? In early childhood, there's a lot of discussion about needing a diagnosis in order for people to receive services. It's a mechanism to help determine medical necessity and reimburse for those services. But when you talk about diagnosing a 3-year-old with something like major depressive disorder or bipolar, you're hesitant to do that, and rightfully so. But we know that early intervention is key, especially when those children have been exposed to repeated traumatic experiences. There's a way to translate DSM diagnosis to what that looks like for young children birth to 5 in order to allow for that reimbursable services. Other states have done it, Florida, and there's a way that we can easily do that here, so we're not unnecessarily labeling young children, but getting them the support that they need. We also can take a look at what programs, being data-driven, what programs are working right now and where we're not seeing effective results, look at how to redirect some of that funding. So when we take a look at our asset map that I mentioned earlier of what's working here, we could see programs that aren't having the results that we need and retooling that and redirecting some of those funds. So it isn't necessarily always about simply more money, but looking at how to more effectively rearrange how we spend. And again, as Suleyma mentioned earlier, the issue that we have with lapses in children's insurance coverage, not only does that impact children directly in their ability to be successful in school, and quite frankly for parents to be able to be successful and work as well, and they're not getting called consistently to come to schools to address their child's behavior, but what that does to their bodies going on and off medication is a serious issue. And if we can have consistent coverage for kids, that means consistent care for them as well, and better health and education outcomes. So knowing that 65 to 70% of the children in our juvenile detention centers have a diagnosable mental illness, knowing that repeated traumatic experiences and being in the child welfare system has a significant greater likelihood of challenging behavioral health issues, knowing that having a behavioral health challenge that significantly impacts your ability to be successful at school. Those are all different systems and touch points for which children can receive services. But they are not always set up to successfully speak to each other well. So as kids move in and out or receive services at school or then receive services through DJJ or receive them through child welfare, their provider could change multiple times, their medication could change multiple times, and that's a traumatic experience in and of itself. And then providers are not set up to successfully treat students. We hear from pediatricians or psychiatrists where children come to them and they have no idea the medications that they're on, how long they've been on them. Sometimes they have 3 or 4 medications. And so figuring out a way to set different systems up for success of how to do that warm handoff as children receive services would be incredibly helpful. I think Lamar County is a strong example of that you've heard before, and we're also working right now to get DFACs into the fold in that program. And adopting in general that systems of care principle will be helpful. Telehealth is also an incredibly powerful tool here when we think about children in foster care, as they are an incredibly transient population. They often move to homes throughout the state, leveraging telemedicine to ensure that they see that same provider throughout the years would create that consistent care that would help them be more successful. Identifying and treating needs early. Project Aware has a screening component, as Dr. McGibbony mentioned earlier. Department of Public Health has a new initiative, Help Me Grow, that's going to work to coordinate all of those different systems that screen children and identify them early. We know that when we identify mental health needs early and get treatment early, we are not having the outcomes that I spoke to earlier about deaths. For children 15 to 24, suicide is the second leading cause of death, and for ages 10 to 14, it's the third leading cause. So it's a very real issue that can become fatal if we don't address it early. And of course, we are strong supporters of PBIS. We know that system, that approach is effective. We also know that if we don't have referral systems in place or resources, that minimizes its ability to be effective. And so some of those private-public partnerships that I spoke of earlier, Project Apex, is a way to address that. And The seventh component is about culture of awareness and prevention. If there isn't that culture where people feel like they can express that they have a need, if kids can't come forward or parents feel like they can't come forward, that they will be shamed for that, then they're not going to get the help that they need. And out of school time is a big component of that. We know that many of our youth are left unsupervised between the hours of 3 to 6, and it's a very vulnerable time for them. And our out-of-school time providers are a great opportunity for us to address that need. DBHCD has therapeutic clubhouses, and there are many other out-of-school opportunities for us to provide that kind of support for youth. How do we know that we're making a difference? Creating an evaluation improvement framework, and the council will be a great way to do that we are looking at a core set of data from workforce to child outcomes to know that we are actually making a difference. And if something isn't working, then we can pivot and try something else. The IDT is also a strong place to do that work as well. They have a core component that they work on the highest need kids or systems involve youth, but they are a part of this equation, and they have a way that they evaluate the work that they do as well. Looking at policies to see and make sure that they are having the implementation impact that we are wanting them to have. As Sulema was mentioning in Lamar County, that's a great example where those services are available. They should be reimbursed. Is that actually working? And what are some of the barriers that remain in order to address that? And then lastly, we wouldn't be complete without that communication and advocacy component to make sure that we all are continuing to aware that this is a large issue here, that we have champions behind that issue, and that there's continued communication in all of our communities to make sure that we are reducing that stigma so people feel like that they can get the help that they need, and that where kids are every day, schools, they are supported. Just remember some of those key facts that we spoke about earlier, that this is an issue that impacts tens of thousands of our youth. In fact, over 500,000 of the youth in our state are impacted by behavioral health needs. And that if we don't start addressing it, that it can become a fatal issue. And that we can address it, and that a reform council would have the mechanisms in place that only analyze the data, what's working, what's not working, what's missing, and what's possible that we can do. And that a reform council also would have the mechanism to make recommendations of prioritizing policy and programmatic change. So thank you very much for your time.
Thank you, Dr. Sitkoff. It's so powerful to hear so many things that have been talked about, like you say, in different spots. I mean, just so many of the acronyms, I think, was that the word you were trying to think of, Joyce? Yes, acronym. So many of them that we hear passed around all the time now are meeting one another in each of these documents together and backing one another up, and we're seeing the incredible positive outcomes in different places. Now we've got to figure out, as you say, how to pull them all together. Are there any questions? Renee, tell me your number down there. We've been joined by Senator.
Push the button.
Yeah, thank you.
How about that?
That's great.
Thank you, and I'm sorry I missed the last meeting. I had two questions. I know that we have put some health I don't know what the right word is, clinics in elementary schools. And I know we have a pilot project, and I'm not sure what counties those are, but, I'd like to see them expanded. But don't you think as an important component of that is the telemedicine part of it to have, because we have the 8 million people in Atlanta and we have the psychiatrist in Atlanta, to have that telemedicine component with child psychiatrist, which is like finding a needle in a haystack, or psychologist, or whatever professional you want to use in that telemedicine scope. But don't you think that there is additional money that needs to be put into that program? Because I've been looking at the telemedicine cost the appropriated money, and it's not as much as I'd like to see. What do you see as a vision for that?
Well, thank
Or
you
do
for
you
that
think,
question.
or do you think the CSB route of putting a contract provider in the schools would be better money spent than the telemedicine component?
So I think there are a few things. I agree that there's a parallel process of trying to grow the number of actually psychiatrists we have here, but realistically, we need to make sure we expand their reach. So that's one. Two, we have a significant amount of telehealth equipment in our schools already. Goodness, it's over 80 schools at this point across the state.
Right.
And I think there's a way that we can figure out how to more effectively use the ones that we have there and get that right. Earlier, Salima Salgado from DPH spoke of a pilot program in Lamar County that's doing behavioral health telemedicine. And that's where we partnered with the CSB to use their psychiatrists through telemedicine, and then had their therapists in the school. So it was a combo. We've got the therapists in the schools, and then we use the telemedicine for the psychiatric component.
So do you think that's the route to go?
It showed some promising results so far. I think we'll know more at the end of the year, but I think it could be an incredibly effective model to have that combination of on-site supports, because I think that's going to be critical, particularly if a crisis arises, and to have that where teachers are able to have that interaction and get that support as well from the on-site provider, and then be augmented by the telemedicine for the psychiatric.
And then the other question is, I know we put money in the budget for suicide prevention, and we have a group that does that. I just think they need to be expanded into what you're talking about, like with this telemedicine, to hook up. I think the services are there, they're just not coagulated, they're not interfacing enough.
Yeah.
And we have a lot of advocacy groups. It's just like a lot of disjointed groups are working on the same topic. It's just that they're not joined.
I think that's an incredible point to be made, that sometimes it's not within an overall health systems of care. And when it's not connected within a systems of care, it is not as effective as it could be.
Yeah, the part of the thing is to remember that telehealth is a tool as opposed to a system.
Right.
I think that's where gets a lot of, so the utilization rates, for instance, are quite, from what we can tell in schools, are quite low because there hasn't been thought given to integrating into a system, but also not thought given to out of school time, summertime, what happens then, how do you get access? And then the other piece of that, of course, as you know, is that a number of there's so few pediatric behavioral health providers in our state that they're not beholden to Medicaid to support themselves. And so a lot of folks won't actually take patients because they don't have to. They're already booked to the gills already.
It's a huge problem.
Yeah. The other thing I would say is, to Polly's point about it being a tool, when you've got providers and that combination of them in the schools as well, it helps change the culture of the school and provides that comprehensive support needed for children. So
and I think having an MSW would go a long ways too. My last question is about I'm working on legislation for exactly what the previous speaker and some of what you're talking about is data integration, that money and data follows the child and follows the person. And I hope that y'all will look at that legislation and help me with it, because I think that's one of the, like the gentleman was talking about, the Behavioral Health Coordinating Council. I wrote that legislation. I go every 4 months or I call in, and they have done great things. Could they do more? Yes. And that is the only time in state government, and for y'all, if you don't know, I know Katie goes religiously too. It's the only time in state government when agency heads sit down at a table and talk to one another other than when they meet with the governor. It's the only time. And every one of those people, they don't all come at one time, but they do send a representative. But we have accomplished a lot, wouldn't you agree?
Absolutely.
Because it forces them to sit down, and she and I are the appointees. But this thing about data integration is what will also force them for their agencies not to be separate fiefdoms, that the Board of Education talks to Public Health, talks to DHS, talks to DBHDD, so that it's a lateral system and not longitudinal. Mm-hmm. And it forces them to share their data, and that when a kid is in Public Health, they're also in Board of Education. And I hope that your group will help me with that legislation. It's a huge piece of legislation, but I hope you'll help me. And I think it will help children.
I can't tell you how many times we hear of providers that a child comes into their office and they have no history or idea.
Right, and that's part of the problem with foster care. Mm-hmm. But if money and data followed the person, it would simplify it. And it would be a more seamless system of taking care of people.
Sounds good to me. Thank you. Thank you for sharing that with us, too. Representative Chandler.
Now, Renee asked my question.
Oh, great. Well, Renee already did it. Any other comments or questions from anyone? Oh, Renee? Utterman? No, we're going off. Okay. Buttons are lighting up and going off. So thank you so much for
Thank you
giving
for
us
the
some
opportunity.
good stuff. Thank you. And for the work that y'all do constantly for our children. Appreciate it. Okay, so next, we have one more speaker, and then we'll go into public comment. And I would remind y'all, if anyone wishes to say anything, we do have a sign-up sheet that I'd like for you to give us some information, and we'll go into that after this last speaker. Felicia Rissick, I hope I'm saying it right. If I'm not, y'all correct me. With Lakeview Behavioral Health is here to share some with us. And Felicia, we have either the microphones at the table or here, whichever are most comfortable for you.
This is fine.
Okay, great.
One second. And you did say it correctly. It's Felicia Rissick.
I got lucky.
It's exactly the way it's spelled, actually. Thank you so much to the committee and to you, Katie, and to Renee Hunterman and to our lobbyist, Acadia's lobbyist, Cynthia Gars, for giving me the opportunity to come and speak today. I've been listening very carefully to a lot of the things that are being spoken about, a lot about children, which I'll get into as well, with respect to what I'm here to speak about. We're all here because we care about, positive outcomes, creative solutions, in addition to being responsible stewards of, funding and resources and that sort of a thing. Some of the issues that are specific to Lakeview and Acadia, and not just Lakeview, Acadia has facilities in South Georgia and Valdosta, as well as in Riverdale, Georgia as well. I think I'll actually start by speaking about some of the issues related to children. Recently, I have written some white papers and have spoken with DFACS and had the opportunity to meet Mr. Cagle, and then also Renee Hunterman, who thank you as well for letting me speak today, has had the opportunity to review some of the concerns that we have had. Again, one of the things that I've been listening to since I've arrived is the concern with our children and what happens with them. With respect to Acadia and inpatient psychiatric facilities and sort of how that fits in, one of the big issues that we face is being able to treat these children, well, efficiently, quickly, having access to the ancillary resources that we need, having appropriate communication with all of the different departments, and that would include school systems as well. But specifically DFACS. One of the, and then also related to CMOs and being able to communicate the severity of need and how we can work together, like I said, to provide appropriate care, but also be good stewards of funds. So specifically with respect to DFACS, certainly we're all aware of the complexity and the limitations and all these things, and there's a lot of great work and compassion that goes into that. With Acadia specifically, and when we are treating children, some of the issues that we run into, which we've actually already had some tremendous response in our concerns, which we're really, really happy about. Thank you so much, Kate, for that. But when we get, we are an emergency receiving facility, which means that, and I'll dovetail into the other issues from there. But when a child does unfortunately end up in an emergency situation where they need to be hospitalized and it's not volitional, many times we are getting kids who are either indigent, who are in defects custody, or perhaps not in defects custody, but their payer source is that of one of the CMOs. What happens a lot of times is there is a delay in our ability to care for these children. They come in, they are in crisis, they need immediate intervention of a medical sort. Sometimes they need they can be violent, this sort of a thing. And when we have difficulties getting access to case managers, supervisors, this sort of thing, it actually protracts the amount of time for us to actually initiate treatment. Furthermore, when we're trying to operate within a continuum of care, that also delays that. And again, we want, no one wants a kid to be confined if they don't have to be, for numerous reasons. It's not necessarily in their best interest to be in a confinement. Moreover, it's not cost effective necessarily. So having the ability to get in touch with the appropriate parties, coordinate care, and make sure that these things happen, like I said, efficiently, quickly, responsibly, is extremely important. With respect to, and then it sometimes gets a little more complicated, and I don't want to get too granular or too anecdotal because I realize this isn't necessarily the appropriate forum for that. But, we also, again, by nature and dint of what we do, a lot of times we end up treating children who are abandoned and they are stuck in a psychiatric hospital. And what do we do, and how do we all work together? And certainly Lakeview and our other facilities in Georgia anyway are motivated to find better ways to do that. With respect to those children that are under the CMO payer source, if you will, as a lot of the other speakers have mentioned, early intervention, proper treatment, thorough treatment, not rushing them in, rushing them out, not giving a chance to sort of understand the breadth and scope and all of the different factors that may be contributing to what, let's face it, is a psychosocial situation a lot of the time. And I'll be frank with you that sometimes we're not always afforded the ability to do that. And again, without getting anecdotal, the recidivism is extremely high. And again, I don't want to get anecdotal, but quite literally, just in the last 2 weeks, we have had 4 children readmit in our facility, just in the last probably 10 days, because of struggles with being able to provide the proper treatment in the right time frame. So certainly that's very frustrating. And again, it may seem one way on the front end, but in the back end, it's to the detriment of the child to keep them in that institutional cycle. But again, it ends up actually being sort of ineffective, again, like from a resource perspective, to keep cycling in and out of the hospital if they're not treated effectively throughout there. Just recently, we, Lakeview specifically and Riverwoods, were granted part of the DBHDD contract to treat the indigent children, which has been, I think, very critical. I can speak directly to the fact that certainly we're aware of this unfortunate need, and we have served many of these kids already. Which I guess then I'll dovetails into what I'll speak about on a sort of larger level with respect to the contract at large and there needing to be more resources and access. I didn't do this, and I'll do it really briefly just to give a little bit of a background to underscore my circumspection of the landscape here in Georgia. I'm a licensed professional counselor. I've been in the field for 13 years. I've worked at 2 inpatient facilities. I've worked for commercial managed care and CMO managed care. I've also worked in the CSB system, as well as in the outpatient community. So I feel that I have a pretty good understanding of how all these things sort of fit together. And in fact, I was part of the pilot that started the hospital bed contract that has grown significantly, obviously, since it started. At any rate, I think that everybody knows right now there's been tremendous, impressive, exponential growth with respect to the expansion of CSUs, all of the things that the ASO has accomplished, but I think that we know that there is still an ER crisis. There are still people that are not able to get served quickly, efficiently, and so on. I can tell you that at the facilities that Lakeview serves, primarily Riverwoods. I don't know why this keeps going in and out. Primarily Riverwoods and Lakeview. We actually serve a lot of those same areas. So I can tell. Thank you. I can tell. I'm not used to speaking in a microphone. I talk so loud without one. I don't typically need one. Anyway, we serve a lot of those same areas. So we serve Forsyth County, Hall County. We get a lot of referrals from South Georgia, St. Francis, from Columbus, regions 4 and 6, all of these same regions that are also part of that contract, which Acadia only has the ability to serve the children. And it's hard to do so when we're not part of the whole system, when we're also serving a lot of these same individuals. And again, like I said, we get referral calls all the time about these patients because we serve those exact same areas. Additionally, it seems sometimes to the detriment of the consumers themselves when they're coming all the way from South Georgia to be treated, upwards, up even further north of us when there is a facility in South Georgia. So I certainly, for the benefit of the consumers, the access, the emergency room crisis, and just in witnessing it all and seeing what the calls that we're getting and serving and sort of, again, being aware of the whole landscape, I think that it would contribute to some of those crises. So that's really, again, thank you so much for the opportunity to speak. I've already gotten a tremendous response with respect to the DFACS issue. I think it's an ongoing thing and struggle, and we're all trying to work toward doing better for our state's children. But again, I think there's a bigger issue sort of writ large with respect to access to, throughout the state. And certainly our facilities would like to collaborate and like to help with that.
Well, thank you. Thank you for your comments. I'm glad that the conversation with GFACS is making it a little bit better, hopefully. I do think it is so much about communication, you're right. So, bringing that up, appreciate it. Are there any questions among the members at all? I would ask, so y'all only do children? You're only children, or are there any of the facilities under your umbrella that also have adults?
We treat adults and children. Specifically, the only ones right now with respect to the indigent contract specifically are the children. Mm-hmm. But we treat from 10 to, whatever, as old as you can be and still require a psychiatric hospitalization. And this is true for all of our facilities. So both.
Right. Well, and I appreciate the concern that you have for children because, as I know we've heard today, the earlier we can begin to help that child be whole, the better chance we have of not taking care of them later in adult life and helping them be productive citizens here in Georgia.
Yeah.
Yeah. So thank you. Thank you so much. Appreciate it. Okay. No other questions. Good. You told us what we needed to hear. Same. That's good. It's good. It's good. Good sort of.
Thank you.
Thank you. Good sort of ending on bringing together the same concerns I think that we hear a lot, which is, it is definitely a crisis, no doubt, and access and those who are in need, financial need, certainly come to forks in the road at times. So thank you so much. We will move into now our, we call it public comment, but in all honesty, none of y'all are public, so please know that. It's kind of a weird, let's just call it comment. Let's come, y'all are the ones who really help us a lot. So let's just go to the comment time. And first on the list is Ellen Yeager. And when each of you come up, whichever microphone, I'll turn them both on, so wherever you're most comfortable. Just make sure you introduce yourself, because I know you, but maybe everybody doesn't. Tell us a little bit about yourself.
I'm Ellen Yeager, and I'm actually here today because Dr. Smith from the Georgia Parent Support Network asked me if I could come and give you her perspective. I will tell you that I don't have notes anymore, because basically every piece of data that I was going to give you has already been heard, and that's very, very good. It really reinforces what we know. And there is no doubt Georgia is making great strides. I do want to give you, though, a slightly different perspective from Dr. Smith's view. The Georgia Parent Support Network works with kids who are not in school, basically. They're kids who kind of roam the streets. They are predominantly very low income, predominantly kids of color. Many of them live in homes where it is not a question of educating parents, because often they don't see their parents, and sometimes their parents have their own illnesses, whether it's a mental illness or a substance abuse issue, and so these kids are really left on their own. I know no one here wants to see any child left behind, and so there is another challenge, and it's how do you reach the kids who are not traditional kids? And there is no doubt all of this has to start early. I mean, everything you've heard, absolutely correct. So how do we reach the kids who are not traditional kids? And Sue has been, Dr. Smith has been really struggling with this. What we know is when these kids do go to school, they're usually thrown out. And when they're thrown out, they're usually put into a school that really does not address their mental health needs. I don't think anyone started the GNET program to be a program that did not address their mental health needs, but unfortunately, that's what's happening. So Sue really is challenged to meet their needs. I can tell you that with all the data we know, kids from the first signs, symptoms, behavior issues, to the actual diagnosis and treatment is an average of 10 years. So if you said that about any other illness, you already know what the outcome would be. It would be terrible. And in fact, there would be an incredible public outcry. So we face stigma on many levels. So again, much of what I was going to share with you has already been shared. So let me just talk about the one point that has not. A lot of the kids who you read about in the paper are kids who have truly been traumatized in their own schools. And the word bullying is overused perhaps, because it's more than bullying. These kids really are traumatized. The two boys who were seniors at Columbine kept very long journals of what happened to them for years and years. And the outcome is certainly not anything we would ever want to see again. I know there was some discussion about medication at the last hearing. I would tell you that it's a really long, complicated subject, because we see kids who are over-medicated. We see kids who never have an opportunity to have medication. One of these boys was on an SSRI, the other boy was on nothing. The thing I think that was most upsetting to me was the more I read about Columbine, these two boys had produced a video that basically showed exactly what they were going to do 2 weeks later. The video was shown in an English class. Neither boy was taken for help. Neither boy. Nobody contacted their parents. Nobody talked about the violence, anything that actually this happened 2 weeks later. So they previewed what was going to happen, and there was no intervention. So when we talk about some kids falling through cracks, some kids fall through holes. And we need to address all of these kids. There is no doubt there is a great discrepancy in kids who get help and kids who don't. And if you look in the juvenile justice system, you will see the majority of those kids are kids of color. So somehow, as much progress as we've made, and as proud as I am of the work that's been accomplished, and the absolute dedication and compassion you all have, there still is so much to be done. I would suggest one thing. The program that Gary talked about and is so successful is aimed at adults understanding behavior, adults making a very definite positive step forward in how their climate is handled. But no one's talking to the kids themselves. So from a very, very early age, right through high school, kids with any kind of behavioral problem are truly discriminated against. The stigma there is incredible. And part of it is just kids who are different are treated differently. And until we can get to the point where kids who have any kind of behavioral problem are treated the same way a kid who was identified as having cancer or diabetes would be treated in the school, we're not going to make the progress we need to make. These are their peers. These who they look at for approval. Peer is very important at every age. So I think we need to look at how are we going to expand this. And clearly what you say to a 3-year-old would be very different than what you would say to a 15-year-old. At least I would hope that would be the case. But we do have to start looking at innovative ways to let kids know different doesn't mean bad. Mental illness doesn't mean dangerous. We have to really get the stigma that's associated with these kids erased. And we really have to look at how we support every one of these kids. So thank you.
Thank you so very much. You do have a question, Senator Unerman.
I just wanted to say, I think when you said, and you're really inspirational, Ellen, every time I listen to you talk, because you're so wise and you know what you're talking about. You've been in the system so long, and I appreciate it. Is this issue of data integration goes directly at what you're saying, because just follow with me. If you had a woman who was addicted to heroin, and she delivered a baby at Northside Hospital, which is the #1 hospital in the United States, you know when that baby's born, it's addicted. And you know that it's going to have failure to thrive. You know you're going to have to detoxify that baby. You know that when it enters into pre-K, that automatically it's going to have problems. It's going to have ADD. It's going to have the inability to follow directions, to learn to read. You know when it's in the 3rd grade, it's going to fail its test. So if you have that data integration, not only could the state be prepared, the providers be prepared. You know what's coming down the line. You know you're going to have to exert that amount of money. And you know that if it had a seamless system where the Board of Education would be talking to DBHDD, that they know and they're prepared when this kid starts entering the school system. Don't you think that is one of the keys to being able to treat them better, to a holistic approach, and not just the physical part of it, but the psychological part? And that data integration is a part of it.
Oh, no, absolutely. I mean, you know, you and I have worked on issues like this for a very long time. Absolutely. The more we see communication between the departments, always the better outcome you're going to get. And Dr. McGivney clearly said DOE cannot be responsible for everything. And mental health goes through behavioral health and co-occurring. You know, there hasn't been that much discussion about substance use and how that impacts, you know, kids with behavioral health, mental health. So, you know, these are complicated issues, and what you're talking about with cocaine addiction and other illegal drugs is also true with substance use, with alcohol.
Right.
You know, and these kids are often put on meds that actually accelerate their behaviors rather than help them. So, yeah, I mean, coordination is key, and I think until Georgia can really figure out how to allow the communication and the funding to flow.
Right.
And what you talked about in terms of money following the need, not the department.
Exactly.
Things don't change very much.
Right. It's the silos, and this helps eliminate those silos and talking to one another.
Thank you. Thank you all. I really appreciate the fact that every year you're here and fighting an incredibly good and challenging fight. So thanks.
Oh, I equally appreciate that you're here and helping us lead that fight. It makes a huge difference. Thank you. Thank you for your wisdom, as Renee said. Next is Kelly Robinson, the Douglas County Board of Commissioners, I believe.
Yes.
Yes. Oh.
Good morning.
Good morning.
Good morning, Madam Chair and Vice Chair and all committee members. And sorry, I've got a sore throat and everything else out here in this weather. So I hear I'm on day 3, so I'm sensitive. Yes. So I'll be quick if you don't mind. I was here on day 1, and I'm back again, just sort of in the closing parts of your efforts to address mental illness. And I haven't been able to hear all of it as far as the days in between the first and this one, but it's been very, very encouraging to hear that you're tackling this. I mean, obviously everybody in this room are committed to the work that's being done here, and hopefully we can move ourselves forward. I'm here to speak more specifically to local. Again, my name is Kelly Robinson. I'm in my 3rd term as a county commissioner. You know, Douglas County happens to be right across the river, right across the Chattahoochee, so it's not very far. And it has an interesting background. I'm going to give that to you as I get into my comments. You know, we've got 140,000 residents that are there. And when you think about mental health, right now we're looking at mental illnesses being treated in our jail as a conduit. Our jail holds about 800 people. We spend $120 million on a jail that holds 800 people. That's $150,000 per person, right? And I'm here as a banker. I've been in the banking industry 25 years. I teach at Georgia State University. I teach statistics to sophomores, entrepreneurship to juniors, and I teach the capstone strategy class in J. Mark Robinson. So I'm all things financial, right? And so I'm only bringing that perspective to the table. I can't speak anything about public health. It's been very interesting, but I follow the money. And I encourage you to, as you look at this, is that when I was at ACCG and I heard someone from the state come and speak, and they talked about the general nature of obviously criminal justice reform, and I listened to her, and there's about 1,000 of us in there, and she made this comment, and I turned and I'm like, did y'all hear what she just said? And I was talking to my colleagues that says that the model was not sustainable, that we're moving toward this, these accountability courts, and we're pushing down from the state down to the local level, which is why I'm here. And I said, wow, did y'all hear what she just said? It's like it's not sustainable, right? You got to really see what that was saying. So it's like, okay, they're pushing the model down to the local level, right? So this is about taxes. And I looked at this and I said, okay, so we've got to solve this problem. It says, how are we going to deal with housing if they begin to push it down? Now we know that roughly, and I think one of our judges was here last time, Superior Court Judge, and he may be here, I don't know. I don't see him, but spoke to about roughly 20% of our existing jail population has mental illness issues, right? So back to statistics. So 800 people, 20% have either one or co-occurring mental issues. And if we're spending that type of money to house 800 inmates and roughly 20% don't really belong there, they need to be somewhere else, I began to ask myself, well, where are we going to put them? We have obviously regional, there's some regional hospitals there that we're trying to, their arrangements are trying to be made to sort of be able to deal with this, but it's slowing them in coming, right? And so if we know we've got a moral, ethical dilemma that we need to move away from this, we know that there's a financial, we can't sustain it. We're having to bear the burden at the local level, at the Board of Commissioners. And so then it's like, well, what about this, what they call a residential model? And that's what I'm here to further push on, which is when I hear a residential model of being able to treat, whether it's drug, DUI, mental health, I always think about, obviously, the planning and zoning that goes along with that. I think about, not in my backyard, right? We go, our CSB, which is always challenging to work with, and we made that comment, is it's hard to get anything out of our CSB. So we as a county, seeing that we have a group one, it's called the Cobb Douglas CSB, we have to work with them. It's easier for us to just go directly into the community. We're spinning wheels here, but nevertheless, we've got to get things done. If we as a county have to send our residents over to another county to get services, but yet they come and buy houses over here in my county to provide services, I think that's a challenge, right? I think that warrants looking at, and I'm sure we're not the only ones that have that experience. I'm not here critical, I'm just here as an observation, just, okay, as I follow the money. The second thing I wanted to bring out is that you talked about awareness, and I heard that as a theme. And by the way, I'm legally blind, so I don't see any of you. So if you're waving or telling me, it's okay to nod me. When I think about awareness, one of the things is that in my community, I look at me as a glorified customer service rep. Like I get all types of calls. You name it, as a board of commissioners, we get everything, and we have to obviously triage them where they need to go. But one of the things is that what I've noticed is that people says, well, we're trying to get services here locally, and we can't get any support. And obviously, the answer is to go over to CSB, but like the gentleman said earlier, it's easier for me to go to United Way and say, well, just call, whatever this 51141, whatever the number is, it's easier to go there, right? But then I began to think, well, wait a minute, I'm looking at my budget. I'm on the finance committee, and I'm like, I'm giving these guys money locally to match what you guys are giving from the state level. And I'm like, okay, where's my yield on that money? Where's my return? I'm not getting it back for the residents here, right? So this past year, in this past budget, we allocated $50,000 as a grant, and we're going through CORE, just to coordinate in our community, go out and find some service providers, get out there and get it and provide service treatment, education, you name it. And I'm like, why am I having to go through this? Why are we having to sort of have these two sets? You got a CSB that's supposed to take this, and yet you've got this. We're trying to get stuff done, right? We're local. I got to get stuff done. The second thing is that as we began to expand these courts that you guys talk about, and I know we're talking about mental illness, so I'm going to stay there in that lane, is we have to do our part locally. Douglas County, obviously, we a moderate-sized county. We have no long-term debt. We pay as we go. We do pretty decent. But yet, we recognize we're going to have to make a contribution to this. So we've set aside in this current budget cycle, which hopefully we'll adopt in the first week of December, $250,000 to help our judicial side. In other words, to deal with housing. But I'm like, that's not sustainable. I just can't. I don't have that type of dollar. We're obviously small. We're not like the big counties. And so I guess my question also would be when we talk about permanent housing, not the temporal housing, right? Not the hospital, not the temporal housing through 30 days. We're talking about permanent housing that may be necessary associated with a judicial order. I'm trying to cover a couple of things. Is perhaps consideration of NSP dollars, neighborhood stabilization, which you're already using, that's already sitting out there being recycled, could be considered to be applied for this or expanded for use. SPLOST consideration, if I can spend basically, $150,000 per person to put somebody in, to house someone in jail, could that not be used as a consideration for some of these other housing considerations, which are a little bit more permanent? So think on those things for consideration. These are tools that you already have in place. I'm not asking you to go and create something outside of that, just making some amendments to certain things that you've already given us to work with. It'll go a long way. We do recognize at the local level we have a role to play. We have to contribute. There's no doubt about it that we have a role. We can contribute. We're from Douglas County. We're saying we're here to work with you, but also we need a little help, just a little room to breathe for you to give consideration. Madam Chair, I have no more comments. I just want to give that with you. Thank you, Madam. My voice is going out fast. I'm sorry.
Sorry. Thank you.
Yes.
Thank you for being here. I think we may have at least one comment or question for you, so if you
That's
can
fine.
hang
Yes,
on
ma'am.
just a minute.
Yes, ma'am.
Representative Alexander.
And it's not really a question. I wanted to thank you because your input and everything that you've done in Douglas County for mental illness is the reason why this legislation was written. So I thank you. I thank the judge, and I appreciate everything you do for Douglas County.
Madam, thank you very much. Thank you.
Thank you, and we hope that goes away real quick.
Thank you, Madam.
Thank you. Okay. Next, Ray Thompson, Georgia Mental Health Consumer Network. And I don't know, Aisha Northington is on here too, and I don't know if y'all were speaking together or separately, however you wish to do it. If you just introduce yourself to us a little bit,
All right.
please.
Well, good morning. I'm Ray Thompson, and I come to you from the Georgia Mental Health Consumer Network. But I'm speaking as a peer who receives mental health services and someone who's in mental health recovery. I have a short story that I'd like to share. 4 years ago, I was compelled to leave the comforts of my burgundy couch. My couch had dual recliners, massaging seats, drink holders, storage compartments. My couch sat in front of the windows of my family room. Day in and day out, I sat on the right side of my couch. It was my comfortable place, but there were no opportunities for me to recover sitting on my couch. The couch became old and worn. The features still worked, but the couch was in pretty bad shape. I lost my place. I'm sorry. And that was the only reason I threw my couch out, was because it looked bad. I purchased a new one. It was big. It was leather. It wasn't quite as comfortable as my old one. And so it made it pretty hard for me to stay there on the couch. So because I no longer had this comfort place where I could just sit day in and day out, I felt compelled to do something different. I wanted to get up. I wanted my life back. Additionally, my daughter was about to graduate from high school, and I wanted to set a better example for her as a mom and as a woman. I desired to take control of my life. I wanted my life back. So I wanted to launch my daughter into adulthood. I searched online for a therapist, and I found a provider through my insurance company. I found a great therapist. One of the immediate things she did was offer me hope. She told me, "Ray, you can recover." And I was like, wow, really? I'm not doomed for the rest of my life? She said no. So as I went on, I continued to research options for my recovery, and I found the Respect Institute. At the Respect Institute, I learned to write my recovery story, and I learned to share my recovery story. I was chosen to be one of the 3 speakers at my Respect Institute's graduation. A month later, I went back to support the Respect Institute class that graduated after me. While I was there, one of the facilitators for Respect Institute suggested that I check out the CPS project. And the CPS is Georgia Peer Support Project. So I found the required information on Georgia Mental Health Consumer Network's website. I applied. I was accepted to the training. I passed the test. I became a Georgia Certified Peer Support Specialist through the Georgia Mental Health Consumer Network. Each day I meet new people. I also meet people that I see on a regular basis more often. And with them, I get to share relevant parts of my mental health recovery story. I get to now ignite or fuel sparks of hope for other people. I'm so sorry, I'm nervous. That way I'm allowed to keep my promise to my children also by being in recovery. I promised them that I'd never leave them, which meant that I'd do whatever I had to do to take care of myself, to be present for them. My peers have become my greatest form of support. I met a lot of them through training, through participating in the wellness activities at the Georgia Mental Health Consumer Network. And from sharing my experience, I'm hoping today that you all will consider some expansions for additional peer support, wellness, and respite centers throughout the state of Georgia. I have peers, colleagues, and friends, particularly in the Augusta area, who keeps asking, when are we going to get a respite center here in Augusta? And for me, I really feel like that's a very good question, because Augusta is my home, and that's part of the reasons why I never returned, because I didn't feel like there were the supports there that I needed. I'm happy here in the Atlanta area. I love my position at the Georgia Mental Health Consumer Network, working as a certified peer specialist. My hope is that more people will have access to the services that we provide, and that we'll be able to reach more people who can come off of their couches, who can come out of the back bedrooms being hidden out by family members. I'm hoping that we can be intentional about connecting with people who live out in the elements, and to help remove that disabling power of stigma and shame. Secondly, I ask you all to consider some avenues for certified peer support specialists to support school social workers and counselors, and more importantly, support the parents who care for children with mental health challenges. Lastly, once we leave our comfortable place and return to work as certified peer specialists and other positions, perhaps someone can look into offering us some loan forgiveness. We fought really hard to get back our lives, and we've taken positions that don't pay a lot tangibly, but the rewards are amazing. Thank you.
And thank you. Are there any questions or comments? Okay, thank you. Great job.
Thank you.
So, Aisha?
Hello.
Hello.
My name is Aisha Northington, and I also represent the Georgia Mental Health Consumer Network. I had all of this great data. I still have it that I'm going to share. But one of the things that I would like to ask first and foremost is that for support in opening more Georgia Peer Support Wellness and Respite Centers across Georgia. There are two things that I hear a lot from. I'm also a certified peer specialist, and I have been now for about 2 years. There are two things that I hear people ask for more often than not in this field. And one of them is, you guys need to open more centers. We need more centers. We get calls on the warm line from people who live in rural parts of Georgia. There are not a lot of readily available behavioral health services. There aren't places that they can go that support destigmatization as opposed to demoralization. It is the alternative that works. As opposed to going into a psychiatric hospital, being locked in, being told what to do, not being self-directed, not being able to make your own choices and decisions. And one of the things that I've realized through working with the Georgia Mental Health Consumer Network is that no matter what space a person may have been in, they always know when they've been treated with respect. It always shows up. There's nothing more powerful that I have realized and seen other than being in a room with a person just like me and saying, you know what, I've been in this hole and I can show you the way out. Recovery works. Together we can do it. We can open more centers. We can create more environments where people have a voice and their recovery is sustainable. If you all would please support us in this opportunity to, there's so many different things that we offer at the Wellness Center. One of the things that we offer is wellness activities. We don't call them groups. We have wellness activities. The Peer Support and Wellness Centers are open 7 days a week. So we never close. Well, we do have closing hours, but we're open every single day from the hours of 10 a.m. to 6 p.m. People can come and do computer classes. They can do trauma-informed peer support. They can learn about wellness recovery action plans. They do DTR because a lot of the people who come are dually diagnosed, and so they do have a mental health challenge as well as a substance abuse or alcoholism. And there's so many things available. We have a warm line where people can call 24 hours, 7 days a week to receive peer support over the phone. And it's a way for us to provide peer support for people on a continual basis without having to go into a hospital, without having to be locked in. They can just come in and say, you know what, I want to talk, or maybe I want to do a wellness activity. And so we provide that support for people 7 days a week. I have watched peers come in one way and leave after a amount of time being totally different, feeling confident about their recovery, being ready to make choices and say, okay, well, this medication may not be working. Is it okay if I go and talk to my doctor? And finding that voice and learning how to self-advocate is very, very important. Thank you so much for all that you have done. It hasn't gone overlooked. Thank you.
And thank you. Are there any comments or questions? Absolutely. Thank you. Keep fighting that good fight. It's good. Appreciate it. Okay, next, Elizabeth Apley, Central Outreach and Advocacy Center.
Good morning, Madam Chair, members of the committee. My name is Elizabeth Apley. I'm here on behalf of the Central Outreach and Advocacy Center, a mere 100 steps from the front door to the Capitol. We serve homeless and near homeless people in the basement of the Central Presbyterian Church, helping to restore them to their community. We provide a variety of services, helping to connect people to shelter, to food, to benefits, to health care, to legal services, to employment. And one of the keys, one of the things we spend much of our time and resources doing is helping people to get ID cards. And this is an issue that I know you raised in the earlier meetings. This is an absolutely essential tool for people to be restored to their community, because you cannot get benefits, you cannot get a job, you cannot get shelter or health care without an ID card. And so the population that we serve obviously has this intersection that you have been dealing with of mental health, severe and persistent mental health issues, of being cycled through the emergency rooms, ending up incarcerated. You will hear from the state prison system. They will tell you that they are the largest provider of mental health services in the state. And they will also tell you, as Commissioner Nail testified to the Criminal Justice Reform Council last year, that more than half of the people leaving state prison in Georgia last year had no identification. So they left the prison with $25 and a piece of paper called the Department of Corrections ID that no one accepts as ID. So these people come to the doors of the OAC, and we help them to get their birth certificates, which is a necessary first step to getting the state-issued ID card. It costs $25 to get a birth certificate in Georgia, and if you want the luxury of doing it online, it's an extra $8. We spent over $16,000 just for the birth certificates alone, not for the staff time or the money orders that it took to get those, and that's only because the OAC had to ration the number of people we could help. We could have helped many more to get birth certificates. The reality is that that $25 fee should be waived for homeless and near homeless people in order to help them to be restored to their communities and avoid ending up in the emergency room and in jail. The policy of the state of Georgia was to do just that prior to the recession. Since then, the fee has been reinstated and not waived. We are in discussion with the Department of Public Health to get them to accommodate this obvious problem, but we haven't arrived at a solution yet. We hope that you will help look at this issue. There's also, and I want to add to that in working with the Criminal Justice Reform Council, the prison system has committed to changing their policies. They have made changes, but as yet, at last report, it was still only 44% of people were being connected to their ID, but they are committed to working on it. Then there's a separate problem with the jails. The people sometimes enter jail with an ID, and it gets lost in the process, and they leave again without identification. So there are two things. One, identification should be treated differently than other items of personal property. We don't care what happens to their tennis shoes. We don't care what happens to their belt or their cap, but we do care what happens to the ID, and that can be kept in a file and returned to an individual, even if they move from one jail to another. And systematic processes should be put in place to make sure that if a person who enters jail without an ID gets the assistance while they're incarcerated so that they too can leave with identification. That is absolutely essential to avoid their recidivating. There's another problem with the issue of getting ID, and that is that Georgia has recently changed its policies to essentially require that in order to get a copy of your own birth certificate, you have to show basically a government-issued photo ID. So it's a catch-22. The more lenient standards that had been in place, allowing people to show a library card or a voter registration card or a bill or a pay stub, have been eliminated. So we are in a very serious problem for homeless people. I want to add some, and we'll provide to you in writing, the recommendations of the housing work group that have been presented to the Criminal Justice Reform Council on this issue of housing, because housing, mental illness, incarceration are very deeply intertwined. And I believe the gentleman who spoke just a moment ago highlighted that issue. One recommendation is that when a person is incarcerated, their Medicaid eligibility should be suspended rather than terminated. Other states have done this. We urge Georgia to follow suit. Second, to those people who have severe and persistent mental illness and would be eligible for SSI or Social Security because of their disability, the prison system should help them to apply while they're still incarcerated so that they can receive that benefit upon release and sustain them rather than force them back into prison. Third, we should create a structure similar to the Family Connection Partnership, which is such a wonderful success, to look at this issue of reentry. There are many local reentry initiatives in DeKalb and Gwinnett and elsewhere that have been very successful in connecting the jail and prison experts with legal services, with local churches, with United Way and other NGOs to help people get access to health care, substance abuse treatment, mental health care, housing, etc. on release, and that greatly enhances the likelihood of their success. But if we instituted something akin to the Family Connection Partnership, we could create state-level expertise to assist local communities in creating reentry partnerships tailored to their local communities, but without requiring each community to reinvent the wheel, as it were. Finally, we urge you to look at ways to increase access to health care, to mental health care for this population with SPMI. There are Medicaid waivers available to support housing for people who are Medicaid eligible, and there are options through waivers that are available to Georgia, even in this time of change, that we hope you will lead in exploring. I appreciate the opportunity to speak with you, and thank you for your attention and your leadership on these critical issues.
Well, thank you for your attention. I know we have one question or comment. Representative Kelly? No, Gardner, sorry.
Thank you for the work you do on behalf of this center right in downtown Atlanta. I've had a lot of questions about the ID card, and I had some conversations with DMV about whether or not they had the capacity to go into facilities and help. I mean, have you ever asked them to come in?
So the Department of Driver Services is working closely with the Department of Corrections at the state prison level. They have finally come up with two pieces of a solution that they're working on for the prison population. One is to create a central repository for birth certificates and IDs so that it is kept in one location and not lost as the individual is in the system, moving from place to place. And the other innovation that they've just started as they're trying to create the electronic matches is to process people when they are first brought to Jackson, where all prison population cycle through. So they will make sure that they have whatever they need and the real ID compliant photograph so that when the ID can be issued upon their release, they will already have it in the system. But as of yet, they're still at 44%, which is a far cry from 100%. And we need more support for the jails because their problems are, they have a lot of locations. They don't necessarily have the funding. And when you're talking about $25 for a birth certificate, it's a big hit on jails as well, even though it's money well spent.
I think that's a really important initiative. I hope you'll follow up with it.
Thank you.
Great. Thank you. Representative Alexander.
Thank you so much for your work on all of this. These are great suggestions. I know early on we talked about a hybrid ID. Do you know much about that, and do you know, as it relates to identification and homelessness and mental ill, what are the best practices in other states? Or
I started to look into that. I have not completed the analysis. It was not as readily available as I hoped it would be. I know that there are states that are using that model. Georgia has committed itself pretty heavily to a real ID model across the state. Some local jurisdictions create alternative or temporary ID cards for people to utilize for the purposes we described, because the real ID, as was presented to this committee, is only necessary to get on a plane, go on a military base, something else. I forgot what the third thing is, but not the things that we're talking about that are the essentials that people need to be restored from homelessness. That may be an option. It would obviously take a commitment from the Department of Driver Services.
Representative Kelly.
Just real quick, you touched on the Real ID laws in Georgia. Isn't the purpose of the Real ID laws in Georgia making sure that only individuals who have lawful status in our country and state are able to get identification and use our services, whether that means travel or use of our state resources?
I wasn't opposing Real ID. I was trying to highlight the fact that there are elements of the Real ID that
my purpose is that I think we keep attacking Real ID, but the issue with the Real ID is making sure that it's people with lawful status in our country and state who are able to use our resources for our country and our state, not those who are here illegally. And I feel like we're attacking that system when it is here to protect individuals who have lawful status in our country, and I want to make sure that we're not going down that road.
I hear you. It was not my intention to attack the Real ID law. There are other alternatives that would help this population without avoiding the issue that you're describing. What the OAC does is help people to get their birth certificates. So we're obviously talking about people who are lawfully present, who are citizens, but who've lost identification by virtue of their mental illness or their homelessness or incarceration. And so we're really trying to focus on facilitating people who are lawful citizens in getting the ID to which they're entitled without putting unintended obstacles in the way.
Okay, that's what I just wanted to make clear.
Yeah, I apologize.
I feel sometimes we go down this road about ID cards, we lose fact of the situation that one thing we are trying to do is make sure that those who have lawful status are the ones who use our services. And I feel like sometimes that's been something that's not come forefront. So thank you.
Okay, that looks like all the questions. Thank you so much,
Thank
Elizabeth,
you.
and thank you for your work. 100
Thank you.
steps away.
There you
Thank
go.
you. And our last speaker is Priscilla Nixon, Deputy Clerk and Family Support Partner from Rockdale. Yeah,
Good
sorry.
morning.
I see you there.
How are you?
Tell us a little bit about yourself, Priscilla. And then
Good morning, Madam Chairwoman. Good morning to the committee. I would like to extend a special thanks and gratitude to Representative Alexander, who invited me personally. I appreciate the invite. My name is Priscilla Nixon, and I am a deputy clerk at Rockdale County Probate Court. There I specialize in addressing strategic plans designed to help families dealing with circumstances that form from their family members that possess mental illness. So basically, I help them deal and cope with the issues that they're facing. As you stated, I am a family support partner with an organization called Georgia Parent Support Network. It's exactly what the title says, family support partner. So I support families that have children with mental illness. Past that, I am a guardian for my mentally challenged brother and main caregiver, of course. And I want to start off by saying, when addressing the mental health issue, public safety, and the Reform Act, reforming may be greater than what we all expect. Some issues that the mental health and disability community face consist of proper system to work in the favor for a person with disabilities, such as mental illness. So the reason why I state what I state that way, disability and mental illness, is because they're separate, okay? And we separate them when mental illness and disability go hand in hand, because it does pose as a disability. That happens to be one of the mental illness community's major issues, is that it's separated at the top. My question is, and I know normally it goes, you have the questions first, why is mental illness separated from disability or a developmental disability? Over a period of time, mental illness is developed and can be a major hindrance. Some may consider mental illness as a form of a disability. So overall, my question is, why have we not yet gotten to that point where we acknowledge and implement that mental illness is a disability? Do we know? It's okay. I had some note cards and things that I would wanted to address. I wanted to share with you guys, but it's already been shared. Dr. I believe Gibson. I'm sorry, McGibney, and Miss
Dr. Sitkoff?
No, Salgoni.
Okay.
They both attacked some major issues. I was very enlightened by an APAC system, which seems to be a very good system. I am in agreement with them. APAC system should be implemented in other ways outside of just that school system. What I'm going to say next are some key points. Like I said, I'm not going to go over what I wrote down because everybody else has already addressed it. I want this to kind of resonate with you. With the APACS program, is what I just mentioned, it's a system and it works. The implementation of education for the parents is what was mentioned earlier. Teachers being trained, police officers or peace officers having sensitivity training, education, a system, and a mechanism. What I will say is that it really boils down to one thing: a mechanism, a system, which has already been implemented. We just overall need not to pedal backwards. We need to pedal forward and use what has already been given to us. The reason why I state that is because we have mental health programs, we have behavior health programs, we have substance abuse programs, we have so many programs that are being implemented every year for something that the other person has already done. We have so many advocacy groups that work separately that need to combine and come together. What I'm saying is, instead of separately moving, we should combine and find some type of way to get the mechanism going, to get this system rolling. So I guess going back to my question, what are we doing about that system? And I also spoke to Dr. McGibney, and he stated, and I'm pretty sure you heard, the Children's Mental Health Reform Council. So it's already been done, but it hasn't been implemented. So I guess that's my question.
Well, I tell you what I would do. I would encourage you to go back. Perhaps you can go online and look at all of these, because all of these study committees will pop up right there, and observe them when you can sit down and listen. I know you're very busy with your work too, and with a brother, but I'd encourage you to look at those, and I think you will find answers from our true experts in the field. We've had the 4 meetings with a lot of testimony. There are also ways to go back and look at the past years of mental health and children's mental health study committees. There is a lot. There's no doubt that access to those, and particularly in certain places in Georgia, are harder than others. And so finding that person who can help you navigate it, hopefully your good friend next to me will be able to a little more after this committee, because she's heard it all now, and she knows she can call certain resources that exist. I mean, that's what these committees are about. So we're kind of at the end of doing that. We'll put our report together, and maybe it's always available online. But I would encourage you. I know I sense in you the frustration.
There's absolutely, I have accomplished my goal.
Right. No, I don't mean in your goal, but in trying to help others and in trying to make sure that those who need those resources, whether it's your own family member or just other people we don't even know. And I think that's the goal of everyone who committed
Absolutely.
to serve on this committee. So as far as answering the why and the how and the what, I'd encourage you to go back and look at these meetings. And then if you don't find your answers, talk to your representative, talk to me, come see us, and let's work on finding those together. Okay?
Absolutely. And just to follow behind that, I appreciate that, but it's not really, I know you're saying some frustration. It's there, is what I'm saying. It exists, and you exist. So obviously, the resolution exists. But I know a lot of times we can pedal back. We can pedal backwards, and we can address some things that the community has already addressed. Advocacy groups are already addressing. And what I'm stating overall is a collective effort. Instead of having a meeting where it doesn't have all of those major parties that could come together at that one head and collectively fix that problem from the ground root up, and as Dr. McGibney said, in the school systems, because that's absolutely where it starts from. I'm stating that we already have the tools that we need, and that we use the tools that have already been provided. I'm just stating.
Great.
And that's it.
Well, great. Well, thank you. I hope you'll continue to help us work on the challenges that we face.
Thank you so much.
Georgia's population grows, and so do these challenges.
Yes,
So
absolutely.
Thank you.
You have a good one. Thank you.
Thank you. That is the last of our speakers. So I would just like to thank everyone. I'd like to thank the committee. I'd like to thank particularly Tara Buchholz and Betsy Howerton. Y'all have been here with us this whole time, and I greatly appreciate that. And now we are going to go to work on creating a document. And I think there's no doubt that the documents that exist, it's been brought forward today, that they are good. And some of those measures are in some of the information that came forward today particularly. So we'll go to work on it. If you go home or as you're driving home, you think of something you meant to tell us or a bright idea, we're all in this together. So let's see what we can do. Thank you for being with us. And this will conclude the public meetings of our study committee. Thank you.